I welcome all the members and postgraduate for this month's monthly meeting. I request Professor L. Venkatakrishnan, sorry for troubling you, sir. Every month you are coming all the way from Coimbatore to give the presidential address.
Good evening to all of you, and welcome to this month's our monthly meeting of the Tamil Nadu ISG. As of now, the information I want to give you is so today we have about 3 case presentations followed by a journal club by Dr. Sridhar Sundaram. And the other thing which I want to inform you is that we are now preparing our multi-center study on alcohol liver disease. We are looking at the prevalence of alcohol. We have to go through it before we send you the final draft. And second thing is we're also looking at one is the prevalence of alcohol liver disease in Tamil Nadu, as well as what are the various presentations. We're not going into too much of depth, but we also have to do more of the prevalence of alcohol liver disease. The idea is how do we make an impact like what we did in rodenticide poisoning, but I don't think the government will accept like what they accepted for rodenticide poisoning, because alcohol is one of the biggest revenue turners for the state. So we are just finalizing. Dr. Shanti did the first draft. Me and Dr. Prem are looking at it, and probably in about 2 weeks' time we should be circulating that. And once again, I welcome you to this monthly edition of the meeting, and may I request Dr. Rubal to start proceedings.
First we'll have the PG session. I request the chairpersons, Dr. Aravind, Dr. Gokul and Hema, to come over the dais. Arul said he said some more time. He's on the traffic. And to carry over the session of the postgraduates.
Good evening all. We'll go to the PG session first. The first topic is by Dr. Dino Abirami from Global Hospitals, Chennai. The topic is Poet for Esophageal Leiomyoma. Over to you, please.
Good evening to everyone. I thank the NISG Secretary and all members for giving me this opportunity to present this case. Today we are going to discuss a case of esophageal leiomyoma managed endoscopically done in our center. So moving on to the case history. Our patient was a 50-year-old gentleman who had nil comorbidities. He presented to us with intermittent dysphagia for the past 2 months duration, and he had associated dyspeptic symptoms in the form of abdominal bloating, which was more postprandial. There was no history of any significant weight loss or loss of appetite, and his physical performance status was normal. So clinical examination was unremarkable, and his baseline investigations were normal. So we proceeded on to evaluate his dyspepsia. We did an upper GI scopy. So this was seen in the esophagus, mid-esophagus, a submucosal lesion extending from 24 to 30 centimeters from the upper incisor, and it caused significant luminal narrowing even after a full distension. This mucosa overlying this lesion was normal, and except for this, the complete upper GI scopy was unremarkable. So we proceeded to evaluate further for this tumor. We did a contrast enhanced CT of the chest, which showed this tumor arising from the esophageal wall and causing significant luminal narrowing of the esophagus. So it extended craniocaudally to about 6 centimeters and anteroposteriorly to about 2.5 centimeters, and from right to left around 3.4 centimeters. So US evaluation was also done for this patient. This showed a hypoechoic mass lesion extending from 24 to 30 centimeters on linear echoendoscope, and its measurements were around 5 into 1.6 centimeters in So this was found to arise from the muscularis mucosa, and the muscularis propria was intact, and this lesion was almost anechoic with no internal vascularity on Doppler study. So we did an FNB of this lesion with the Francine tip needle, and this biopsy showed spindle-shaped cells arranged in fascicles with abundant eosinophilic cytoplasm, and IHC markers for this proved positive for SMA and desmin, suggestive of leiomyoma. The other markers, c-KIT and DOG1 for GIST were negative. So as the patient was symptomatic and since it was an approximately around 5 centimeter lesion, we planned for an endoscopic removal of this tumor. So a peroral endoscopic tumor resection under general anesthesia was planned and patient was worked up for it. We will move on to the procedure video. First, a submucosal incision was made approximately 4 centimeters above the proximal margin of the lesion, and this incision was extended and submucosal dissection was done with erasing a bleb with methylene blue, and submucosal tunneling was done until we reached the tumor. This is the tumor appearing from the submucosal tunnel, and further dissection around the tumor was done with a TTG knife and a spray cautery. The dissection around the tumor was a bit difficult because of a very narrow space within the submucosal tunnel, but anyhow we found it, we could dissect around the entire margin of the tumor, and this is the dissected tumor appearing after complete dissection around the tumor. So at this point we plan to remove this tumor in whole as with the help of a snare, but it was not possible because of large size of the tumor. So we proceeded on to dissect the tumor into two halves, either with a snare. First we tried with a snare and cautery, but that was not possible because of the thick fibrous capsule. So we dissected the tumor into two halves using a TTG knife itself. And the tumor was divided into two halves, and the proximal half was removed separately, and the second of distal end of the tumor was also removed separately with the help of a snare. This is a removal of distal half of the tumor. And post removal of tumor, this was the appearance of submucosal tunnel. The tunnel was inspected all over, and hemostasis achieved at minimal bleeding points. And this is the mucosal defect which came to approximately 4 centimeters. And this mucosal defect was approximated with the help of hemoclips. This is the appearance post closure of the mucosal defect, and a Ryle's tube was placed in order to assure So these were the steps which I have discussed in the video. This is a gross image of the tumor after excision, and initially after excision it measured around nearly 10 centimeter because of expansion out of the fibrous capsule, but histopathological specimen when examined it was around 7 centimeters. When it was measured, it was around 7 centimeters. So post-procedure recovery of this patient, the duration of this procedure was around 6 hours, and patient was extubated on the next day of the procedure. A CT contrast was done with minimal oral contrast also after 48 hours of this procedure, which showed bilateral minimal pleural effusion with the hemoclips in situ, and there was no leak of contrast into the submucosal tunnel. So patient was started on NG feedings 48 hours post procedure and was allowed on oral liquid diet after 4 days of procedure. The in-hospital stay was unremarkable, and he was discharged on day 5 of the procedure. Patient came to us actually 1 week back for 2 months follow-up. He was asymptomatic, and his follow-up endoscopy showed the mucosal incision was healing, and there is a residual hemoclip there. So, brief review into literature of esophageal leiomyoma. It is the most common benign esophageal tumor. Usually arises from middle and distal 1/3 and originates from the muscularis propria layer. most commonly seen in age group of 20 to 50 years with a male predominance, and it usually is asymptomatic in 50% patients, and when symptoms are there, it usually presents with dysphagia, chest pain and regurgitation and even weight loss. So management of esophageal leiomyoma, whenever the patient is symptomatic, we should go for a excision of the lesion, and whenever the lesion is more than 5 centimeter, it warrants excision. More than 5 centimeter lesions usually will go for a thoracoscopy or an open thoracotomy and excision. But we have tried in this case an endoscopic dissection and endoscopic removal, and a CTVA surgeon also concurred with that decision. So these are few literatures on STER or Poeter for esophageal leiomyoma. The largest case reported is around 6.6 centimeters, and comparison of endoscopic submucosal dissection versus STER. For less than 1 centimeter lesions, we can go for a direct submucosal dissection, whereas for more than 1 centimeter lesions, STER or a Poeter is better because of reduced risk of perforation and other complications. I would like to thank everyone for patient listening.
Were you using any fluid or suction or wash? Because we could appreciate at least fairly 100 to 200 ml of fluid in the chest after the post-procedure CT. Because it looks fairly, you are not using much of fluid at all through the endoscopic procedure, right?
No, sir. Initial.
Hi sir, I'm Vishnu. Hi. So this procedure involves, while we are doing, there may be few small vessels, and when it bleeds, we have to use the fluid. Correct. Since it's a tunnel and the mucosa's muscle is very intact, we do use some amount of fluid. Okay. But irrespective of whether we use the fluid or not, that is actually a reactionary effusion. And some amount of the effusion happens after the myotomy. Here we try to preserve the muscularis propria, but there was a small defect which did happen, and that, as with any case of POEM where we do a complete myotomy, some amount of effusion is
absolutely understandable.
So it is actually reactionary come with the fluid. Yeah, we do.
Fluid for
we do use. Irrigation.
It looks you took little longer time for a normal procedure.
The dissection time was.
What was
the difficulty was not the dissection. The difficulty was the dissection was easy actually. It took just 1.5 hours. Okay. But the difficulty was getting the tumor out. It was quite a large tumor. Once we expanded, just like how the craniocaudal tumor length was only 6 centimeter in CT, once I dissected it was actually 12 centimeters. Correct. As such, the diameter also kind of expanded once we dissected around the tumor. So the mucosal defect was only 4 centimeters. So getting the tumor out was such a challenge. And when I tried to put a snare and cut the tumor into 2 halves, it did not happen. Yeah, the snare really could not cut the tumor. It was very rubbery and elastic, very fibrotic. So the challenge was to take a scope inside this, alongside the tumor into the submucosal tunnel, bend the scope across, and then dissect it in this direction. That was the challenge. That took extra 45 minutes. And then after removing the tumor, we had to close it. The closure device, we don't actually, now there are newer closure devices. 2 months ago, we don't have that. We had to use the line and clip method. Line and clip method, so it was not like a clear, this one. After removing the tumor, the linear incision kind of became like a very oval thing. Okay. So kind of line and clip, that took more time. Okay. So the removal of the tumor and the closure, that took almost 4 hours, not the other one. Nowadays, we have these newer clips, it to come in the market. Just like we have one prong clip and we can catch hold of the one edge and then we can go to the other edge and we can clap. Right. It to be available in India. If those kind of new accessories comes, these cases kind of become less, time duration kind of becomes less, wherein we can see less effusion. I thought it is the prolonged procedure which led to the effusion, and patient was asymptomatic.
So do you again use some sort of saline infusion between, like every now and then, because it is fairly big tumor, as you dissect 2-3 centimeters, then you inject some more saline to separate?
We do use a lot of methylene blue stained saline. Okay. As we proceed, we keep injecting into the submucosa. We expand the areolar tissue to dissect. Otherwise, we cannot. We use a lot of
fantastic job. All the best.
Thanks. Sir? Yes, sir. It's a benign tumor. It shows that there is no internal vascularity at all. As we cut, there was absolutely no vascularity. It was like cutting a eraser or something, like a rubber. It was totally safe.
Congratulations, Dinu and Vishnu, for this showing this excellent case. So if I can ask, where exactly was the tumor arising from? She said it is arising from the muscularis mucosa. Is that it, or it is coming from the propria?
No, it was from the muscularis mucosa. As I was cutting, I tried to preserve the muscularis propria, which we tried, but because of the space constraint, there was one small rent in the muscularis propria. I mean, there was actually a flap valve, like just how we do a poem. Mucosal incision is one side, myotomy is at one side. So distally there was an open in the muzzle layer, which was not bothersome thing, just like how we do poem. But the tumor arose from the muscularis mucosa, as was shown in the US. And same thing we confirmed by while we did the procedure also. You could see that the entire muscularis propria was actually intact.
It was from mucosa. Can you have done a submucosal dissection instead of doing this tunnel endoscopy? ESD would have been an option in this particular case?
A good question. In case accidentally, like we kind of opened up the muscularis propria, had it been ESD and we open up the muscularis propria, that would have been a disaster. So always maintaining the flap valve is useful for us to make it less morbid. And even if there is a lot of saline infusion and everything, we can kind of close the mucosa. That is quite good. If we kind of leave it open, then the patient might probably end up with a pyothorax or a mediastinitis, which is usually the case of VATS and thoracotomy and stuff. I read in thoracotomy some kind of pyothorax sometimes arises. We even asked a CTVS surgeon whether this is how your procedure will be morbid. He actually said that it can be more morbid when we do it with thoracotomy or thoracoscopy. He kind of agreed with us.
Okay. You said the most challenging part was retrieval of the tumor.
Yes.
So one, technique or whatever is to make the tunnel as wide as possible, so that this difficulty would not have arisen.
We did extend the incision, but whatever we did, it was a linear incision. So if I had to actually cut open the linear incision throughout the length of the tumor. In that case, I'll be risking exposing the lumen to the mediastinum. That I was not ready to do. And I was sure that with the line and clip method, we can still close.
A transverse incision would have been better rather than a longitudinal in this particular case.
Maybe, but I have never done a transverse incision in the esophageal lumen wherein I have tried to close the clip. So I was not that confident how it might work out. And we did have the endoscopic suturing device, but the problem is the cost. Once we use the Apollo endo stitch, it's 3.5 lakhs. So financially, we really cannot use the endo stitch here. Clips are much more affordable in this case.
Thank you.
Thank you, sir.
So for the next case.
Thank you. Anybody else? Any questions from the floor? Okay, we'll move to the next case presentation. Dr. Dhanush from PSG Medical College, a case of NAFLD or ESIT.
Good evening. I'm Dr. Dhanush from PSG Medical College. So today I'm be presenting a case of NAFLD or really ESIT. Today I'll be presenting 3 cases and something unique in these 3 cases I'll be telling you. Now first we have a patient who is a 56-year-old female. She's a diabetic for almost 20 years on insulin and OHAs. She has diabetic retinopathy and neuropathy and also had dyslipidemia. Had presented with pedal edema of 1 week duration associated with abdominal discomfort. There was no history of any fever, GI bleed, CAM intake, any breathlessness, chest pain, no other history she had. And on clinical examination, she had icterus, she had a pedal edema otherwise, and BMI was 20. In systemic examination, there was no free fluid, abdomen was soft, no organomegaly, and other systems were also within normal limits. Now, we investigated her, and on investigation, her hemoglobin was 8.8, and platelets were 82,000 with INR of 1.31. And also, she had a bilirubin of 4.5 with a direct fraction of 3.3, and also albumin globin was 2.8 and 2.9, and ALP GGT normal. So, so we worked her up. Her viral serology, including hepatitis A and E, was negative. And we had done a workup for chronic liver disease, which showed negative ANA profile, liver IgG levels, and IgG levels. Our ultrasound abdomen showed only evidence of chronic liver parenchymal disease, prominent portal vein, mild splenomegaly, and mild ascites. We had done an endoscopy. It shows grade 1 to 2 esophageal varices. And a CT was done. CT also only shows there was evidence of chronic liver parenchymal disease with dilated portal vein. So just summing up the case, we have a patient who is long-standing diabetes, dyslipidemia, came with cirrhosis. So our commonest possibility we'll be keeping is NAFLD-related cirrhosis. Now, to confirm, we have asked for a liver biopsy, which I'll come into a bit. There are 3 cases. I'll discuss 2 more cases, the clinical presentation. I'll come to the liver biopsy finally. So this patient is possible NAFLD-related cirrhosis. Now, the second case is similarly a female. She's a hypothyroidism, and she has abdominal distension, bloating, decreased appetite, and pedal edema of 1 month and 1 year duration, and she has history of Ayurvedic medication of 5 months for the pedal edema she is telling. And clinical examination, she just had pedal edema and hemodynamically was stable. And her systemic examination showed a palpable liver along with shifting dullness. And the investigations we done on her shows hemoglobin 10.6 with the platelets of 85,000. And bilirubin was 2 with direct fraction of 1.3. AST ALT was 87 and 38, and total protein 7.6, the albumin of 2.6, and globulin of 5. Now, we are done because globulins are also elevated. She is hypothyroid, so we have done other workup also. So viral serology was negative, and workup of possible autoimmune disease, we did ANA-IF was negative, ANA profile showed Rho52 positive, and liver IgG was negative. Now, other tests showed TSH was elevated, with anti-TPO was also elevated, and IgG levels were also elevated. So, we have done a CT. CT shows chronic irregular liver surface, possible chronic liver parenchymal disease with collaterals, mild to moderate ascites, and mild splenomegaly. And endoscopy shows grade 2 esophageal varices. Now, again, coming to the summing up this case, this case also probably cirrhosis, secondary to either autoimmune or NAFLD related cirrhosis. So, for this also we need confirmation liver biopsy. After the third case, I'll come to it. Now, third case is a 48-year-old female. She is also a long-standing diabetic and hypertensive. She had history of granulomatosis with polyangiitis. Initially was having steroid, followed by rituximab. Now, she was referred to us with altered LFT. She did not have any other symptom except for altered LFT. She had mild pedal edema, otherwise was hemodynamically stable. Her liver was palpable, and other systems were within normal limits. The investigations, hemoglobin, platelets, everything was normal, and LFT showed total bilirubin of 1, AST, ALT mildly elevated, along with albumin 3.7, GGT was 82. So, right now her other workup, while serology was negative, ultrasound shows fatty hepatomegaly, and elastography shows metavirus stage 3. Now, what do we have? We have 3 patients. Out of this, 2 patients are diabetics, and 1 was a patient with hypothyroidism. And all the 3 have altered LFT, and we have 2 people with CLD and 1 person with fatty hepatomegaly. So, around this, the commonest possibility from the first case we had kept was NAFLD related cirrhosis, and second case we had kept was autoimmune bar NAFLD related cirrhosis, third possibly NASH. So, we did a liver biopsy for all 3 of them. So, coming to the liver biopsy findings, what did we have? Now, this is where things get a little strange. Now, with the liver biopsy showed hepatocyte with distinct cell borders and rarefied cytoplasm. If you can, if you can see this granule, there is only pink color is inside. Pink color indicates glycogen deposition. There is fully pink here. There is no. And if you go there is there was fibrosis in the gross staining, and there is MTS staining showing bridging fibrosis, and there is PAS positive granules. PAS positive means once there is glycogen, when you put PAS, it becomes dark magenta. So, this shows evidence of glycogen deposition. Now, also once you put, there is also PASD stain, that is after putting glycogen, initially it stains bright magenta, and this diastase eats the glycogen, and the cells become ghost cells. There will be nothing inside the cells. So, in this, it is diastase sensitive, but in this I will show a better picture of ghost cells. In this, the presumed ghost cells will be all these small cells will be ghost cells. Entire cell will be eaten up, all the diastase will eat up all the glycogen and will be ghost cell. There will be nothing inside the cell. Now this was the given report. It shows liver with architectural destruction due to fibrosis, and hepatocytes are swollen and pale pink, if you can remember. Yeah, see, the hepatocytes are pale pink. And few hepatocytes shows ballooning, and portal tract shows fibrosis and mononuclear cell infiltrates, and group of hepatocytes surrounded by fibrosis and lymphocytic infiltrates. It shows PAS positive but diastase sensitive granules suggestive of parenchymal glycogenation with bridging fibrosis. So this is an entity called glycogen hepatopathy. Okay, now because we said that it was NAFLD was one possibility we kept. This is the two pictures I want to show regarding NAFLD. The one on this side is NAFLD related. So in NAFLD what you will see is there's ballooning of hepatocytes along with Mallory-Denk will be there. Now if you see, there is ballooning with Mallory-Denk formation is there inside. Now in this, if you see, there's no balloon. This is the ghost cell which I was talking about earlier. That is the entire due to the diastase, the glycogen is being eaten up and cells become empty. There will be ghost cells. This is the presence of ghost cells. And there will be pink side. If you can see, compare this to this, there will be more pinkish cytoplasm, and inside also there will be that pink cytoplasm only will be seen. Very pinkish cytoplasm. That is a feature of glycogen hepatopathy. Now this is also the second case. This is a second patient I told you about. You can see in this also very clearly, you can see the pink cytoplasm. You can see clearly the pink is visible here, and it is PAS positive. That is on addition of PAS, there is a very dark magenta color. Yeah, this is the diastase sensitive, showing there is dark pink cytoplasm. And again, case 3, same thing. She also had, there's PAS positive granules. So this is a case of glycogen hepatopathy. Now, glycogen hepatopathy, again, it was usually seen in pediatrics. It was told in children with type 1 diabetes and Moriarty syndrome. Usually, glycogen hepatopathy is rarely seen in adults. There are case reports of glycogen hepatopathy in adults also, but it is also always reported in type 1 diabetes, and it is very rarely reported in type 2 diabetes. So coming to just literature review about glycogen hepatopathy, it is an under-recognized complication of diabetes mellitus due to excessive accumulation of glycogen in the hepatocyte. It is predominantly seen in type 1 and occurs rarely in type 2 diabetes. The ideal differentiation method is only liver biopsy, but other than liver biopsy based on images, gradient dual echo MRI can distinguish these both. And the most important point is every changes is completely reversible once you control the diabetes adequately. That is the most important, because NAFLD it is not a reversible process. NAFLD related cirrhosis. This will completely reverse. So you can expect complete biochemical remission by 2 to 14 weeks after control of diabetes. That is more important. Why you have to recognize this condition and treat this as early, so that if it is reversible, it is a better prognosis for the patient. Now this is the only 3 cases reported in the world in the type 2 diabetes. It is all the cases are reported only in type 1 diabetes. Only 3 cases have been recognized in type 2 diabetes in the world so far. Now pathophysiology, what they saying is there's a rapid fluctuation of glucose, and usually they need very high level of insulin. So there is hypo and hyper variation, so that there is inadequate control of diabetes is the main reason for which glycogen stores increase. Now, if you see the normal pathophysiology, due to the increased glucose level, once the extracellular glucose level increases, the GLUT2 brings it into the hepatocyte, and it rapidly divides and it forms into glycogen. Even when there is excessive insulin in the blood, that is, you are giving an insulin also, what happens is the phosphorylation, that glycogen synthase becomes inactive, glycogen synthase becomes active glycogen synthase, and there is more glycogen stored in the hepatocyte. Now, why does only some people develop glycogen hepatopathy and why some other don't? That is still an unknown phenomenon. there are reports, because there are multiple people with type 1 and type 2 diabetes, and very rarely it is seen. So the complete, why they certain people develop, must be some underlying genetic mutation which is not still understood. Further studies are needed for the same. Now, Berman MC hypothesized that excess the cause of glycogen hepatopathy is excess glycogen deposition, intracellular location, inaccessible to normal metabolic mechanisms, a phenomenon that occurs in type 2 glycogenesis, in which glycogen deposits within the lysosome, rendering them unavailable for phosphorylation activity. This is one hypothesized mechanism. Now, clinical features can vary. It can be asymptomatic LFT elevation to hepatomegaly, or it is usually associated with ketosis, abdominal pain, nausea, and vomiting. As I said, all these were described predominantly in type 1 diabetes, and 14% may progress to fibrosis. Now, investigation, there can be AST, ALT elevation along with ALP or GGT elevation can be there. The definite diagnosis is only made with a liver biopsy. Now, imaging wise, we can make a little bit of distinction. Imaging wise, ultrasound, in general, when you do an ultrasound, what they say is, if you are going to do an NAFLD versus glycogen hepatopathy will be a little brighter compared to NAFLD. That is one difference why we can see. In CT, it will be shown, compared to the spleen, liver will be brighter. That can be one clue, but it is not still it is not a confirmatory finding, it is an associated finding which has been seen. So a bright liver compared to spleen in CT can be clue for diagnosis, and liver density is usually increased compared to patient NAFLD who it is decreased. Gradient dual echo MRI is the powerful tool to distinguish, and T1 weighted dual echo MRI images with in-phase and opposed phase condition could efficiently differentiate hepatic glycogen from fat. If there is no signal intensity difference, it is more in favor of NAFLD, and no signal differences, it is not NAFLD and more in favor of glycogen hepatopathy. Now, this is in one image showing, if you can see, the glycogen hepatopathy liver is more brighter compared to this one. This is all subjective. This is just in few cases it has been found out. It is not a confirmatory. In few cases they have noted that in CT, the liver is comparatively brighter than the spleen compared to a patient with NAFLD. Now, again, it is important to differentiate between NAFLD, as this is a reversible condition, and proper control of diabetes can completely resolve this. So, we have to make sure the difference, you have to know the difference between NAFLD and glycogen hepatopathy. Now, just summarizing what I have already just said, the main etiology is excess glycogen deposition in liver, that is mostly seen in type 1 diabetes, and NAFLD, it shows hepatic steatosis. Clinical presentation can be predominantly diabetes related, that is hyperglycemia, the hyperglycemic symptoms, and also could be asymptomatic. Liver enzymes can be mildly deranged. In this NAFLD, most patients are asymptomatic and they have minor symptoms, and liver enzymes are usually less than 5 times the upper limit of normal. And imaging characters, as I told you, the brightness compared to the spleen, you can see a liver brightness. And the key feature is glycogen deposition in the liver, which is PAS positive and diastase sensitive. That is what I was mentioning. Diastase digestion of glycogen causes the hepatocyte to turn into ghost cells. And usually, even if there are not many number of cases which has reported progression to cirrhosis. Actually, there is no case reported in progression to cirrhosis. Our case may be one of the first case which is where it probably progressed to cirrhosis. And there was a second case, if you have noticed, that patient had hypothyroidism, patient did not have a diabetes. So why did the hypothyroidism cause the glycogen hepatopathy? Now, the hypothyroidism, can be reduced thyroid hormone plasma levels, and beta pancreatic sensitivity for glucose is damaged, which leads to reduced insulin secretion and can increase the glucose levels. And lipolysis is impaired, and transport of free fatty acid from adipose tissue to the liver and vice versa increases. So that is one postulated mechanism. And third person, if you remember, he was a steroid user plus diabetes. So steroid again can increase your hyperglycemia and increase glycogen deposition, and by activation of phosphorylase by glucose, and activation of glycogen synthase. Now, glycogen synthase activated by insulin, which increases following steroid-induced hyperglycemia. Also, that patient was taking rituximab. There, I could not find exactly how rituximab and glycogen synthesis, but in some cases of rituximab toxicity, there is increased glycogen deposition noted all over the body. There was one case report I found. I couldn't find why rituximab, except for rituximab induced drug liver injury I could find, but why it is causing a glycogen hepatopathy I couldn't find. This, and the treatment would be mainly by improving the glycemic control, and there will be clinical and biochemical improvement by 2 to 14 weeks in most of the cases. Thank you.
Thank you so much, Doctor, for bringing to awareness a rather unknown entity of glycogenic hepatopathy. Some of the points I would like to ask is, did you measure insulin levels? Because you are stressing that management of diabetes is going to be curative in these patients. And did you check for insulin? Because the whole mechanism is about insulin resistance, and that is one question. Second thing is, you said these are reversible. You already demonstrated cirrhotic changes in these patients. So how much reversal can you expect in this patient? They've already gone in for portal hypertension, varices, and all those things. So these are the questions I would like to ask.
So first thing, we have not measured insulin levels, but it is in few studies they have demonstrated that it is in short-acting insulin. Short-acting insulin is the one which produces the variation of the sugar levels. There can be hypo and hyper very frequently. Now after the after the introduction of long-standing insulins, the amount of the exertions of glucose is very less. So we have, to answer your first question, we have not measured, and it is more commonly seen in patients who are taking short-acting insulin. And second, once they develop cirrhosis, yes sir, in this patient what happened is, the third patient completely recovered, sir. The third patient have not demonstrated the cirrhosis. The first patient actually biochemically the values have come down. Patient is actually doing better. After insulin diabetic control, patient is actually doing better, and the pedal edema, everything has actually come down right now for the patient. But she is still on beta blockers and lactulactone and everything, but there is no complete reversal for the first patient we have demonstrated, sir. There can be dual mechanisms, sir, but in NAFLD also there is some amount of glycogen deposition they have demonstrated, sir, but the glycogen demonstration is very low. But in our liver biopsy also there is no associated steatosis. Usually if there is some other mechanism underlying with it, usually if it's NAFLD, the closest mimicker is NAFLD, so there will be some amount of steatosis demonstrated as per the liver biopsy. In the first one, there's steatosis less than 5%. So we can put this one on the NAFLD, sir. Yes, sir. Other two patients, both have had, they have cirrhotics, no, sir. They are cirrhotics, no, sir. The other third patient was not, this came with altered LFT. The first two patients are cirrhotic patients, sir.
This entity of this is, you want to say something, sir?
I think we are convinced that it is not NAFLD because the picture, even with cirrhotic changes, did not represent the. If you do a liver biopsy and you claim that insulin and better control of diabetes, do you think the ghost cells will disappear? Do you think the ghost cells will disappear?
Ghost cells, actually they have not, in most patients they have not repeated a liver biopsy, sir, but what they are saying is there should be a biochemical and histological reversal is what they are saying, sir.
But with cirrhotic changes is difficult to...
Cirrhotic, no, I'm not saying, sir. The other patients, if usually there should be biochemical and histological reversal is what they say, sir.
Where do you get PAS positive diastase resistant cells?
PAS positive diastase?
No, this is diastase sensitive.
Sensitive, sir.
There's one classical entity, PAS positive diastase resistant, which is so common in children. Liver disease.
Liver disease, sir.
Alpha-1 antitrypsin deficiency.
In my 48 years of experience in gastroenterology, this is the first time I'm hearing of glycogen hepatopathy. I've not heard of it itself. but 3 cases. But you are postulating some theories, it can be reversed. Still, it has to be proven.
Yes, sir.
You are giving a statement that it has gone to the glycogen, cannot be brought out. Then how can it be reversed? How can it be brought out? You have given a statement explaining that glycogen, once it has gone there, it cannot come back. How do you explain that? You said it's reversible. Because you need more cases.
Yes, sir.
So it's only hypothesis. I don't think it is
Yes.
reversible. You still is a question mark until you get more cases.
Only thing, in those who have not developed cirrhosis, sir, they're saying normalization of LFTs they have mentioned, sir.
No, the problem is you can get fibrosis, can get reversal. I agree. I disagree with your hepatitis C treatment. Fibrosis can be reversed completely. That whole statement that fibrosis cannot be reversed has gone now. I believe even atherosclerosis can be reversed now. If you keep the LDL level below 60.
This,
Is it your message that we should do biopsies for all NAFLDs?
I'll tell you why we did this. Biopsy, we all this diagnosed on a biopsy report. Why was biopsy done on these patients? The first case was 59-year-old lady.
What biopsy, Venkatrishna?
We did a transjugular biopsy. See, the first thing is, the first case came to us with presentation of recent onset of pedal edema. Look at the sugars, 483, 383. And she had ascites. So actually we excluded all the other diabetic nephropathy, all those things. When the liver AG reversal was there, the CT showed a bit the same. In our series, 18 to 20, I'm in female patients, my threshold to do biopsy is less only because I want to rule out an autoimmune liver disease. 18% of patients with autoimmune liver disease will not have all these markers being positive. Same way, when you do, sometimes you have an acute liver failure, you do a transplant in a young lady, everything is negative, explant shows only some necrosis, but 5 years later, she would have come with an autoimmune hepatitis. So our threshold, all these patients were 3. The second patient, why we did was hypothyroid with chronic liver disease. Autoantibodies positive. So again, I think we did a transjugular biopsy to make sure that something reversible won't need to look into it. We don't want to dub them as NAFLD and just keep it. Because if you say somebody has got NASH cirrhosis and they are decompensating, they decompensate very fast unless you transplant them very thick. I think the difference between a decompensation of a hepatitis B, hepatitis C versus NASH-related cirrhosis is, NASH-related cirrhosis people, they decompensate at much lower portal hypertension. They will, at much lower portal pressures, they decompensate. That's why they go rapidly and they die. If you look at the decompensation NASH, they go down very rapidly, not like Hep B or Hep C. So we did this biopsy mainly to make sure that 2 ladies was diabetic recent onset and second was hypothyroid. We did a transjugular biopsy and then to our surprise, we were looking for autoimmune liver disease. For our supply, it came as glycogen hepatopathy by our pathologist and they were very, very sure. We had a CPC on this and then they showed this is what is this. And you look at, even though these people are dubbed as NAFLD, look at the biopsies, absolutely no steatosis. And these people could go this thing. And the first lady, once we controlled the diabetes, she has done remarkably well. Her albumin is 4.2, platelets have gone up to 1 lakh. She's doing pretty well now, once we controlled her blood sugar. The second patient again had hypothyroidism, unknown liver disease. Again, it turned out to be thing with correction of this thing. So we looked at the literature and we found there was, recently also there was a World Journal of Gastroenterology. There was this glycogen hepatopathy and they clearly marked it, what is the difference between this and NAFLD. Probably the prognosis is slightly better and we need to follow up. In fact, the first lady I said to the husband that if she decompensates further, we need to transplant. But right now, once we control the sugars very, very well, she has put on 4 kilos weight, no edema, no ascites, and she looks much better. Platelets have gone up and her albumin is much better. So this is basically our need to do biopsy was to rule out an autoimmune liver disease. Basically, both the 2 patients were definitely female patients and my threshold to do a liver biopsy in a female patient with unknown chronic liver disease is high because I would like to rule out autoimmune liver disease and I would like to still treat autoimmune liver disease if they are very mildly decompensated, the MEL scores are low. I think we still treat them and see what can happen. Sometimes we may be able to salvage them for 1 to 2 years before you go for a transplant. But the biopsy was surprising and then we built it upon this. So now there's a different entity called glycogen hepatopathy, which probably may need some more cases, but these are all the cases which we just stumbled upon, mainly by a pathological diagnosis, and our threshold to do a biopsy is less. Yes, Pirama?
Out of ignorance, how is it different from a milder form of glycogen storage disorder? I mean, what is the difference on the pathology, or how do we differentiate a glycogen storage disorder from a glycogen hepatopathy on biopsies? Or, I mean, why do we term it differently?
Other markers
I'm not very sure. I'd ask her. Do you know? I'm not very sure how is it different. But I think it comes recently. They are much later in age. They don't come much presently.
Clinically, I understand that.
Genetic, we are not checked on this. This is just our.
But GSTs
they come much early in life. They come with hepatomegaly.
Most of the GSTs
But biopsy-wise,
biopsy
I think I'm not very sure. I need to check with our pathologist. Is it different from GST or something?
But some GSTs do present in the adulthood also, don't they? I mean, little later into the adults who...
Yeah, these are all 58, 59. Recently something with hypothyroidism. So what they showed us is that there's absolutely no steatosis. There is fibrosis. And the diastase thing which was positive. PS.
Sure, thanks.
Sorry, couple of points. One is, I think there are a lot of assumptions being made, so we need more clarity on
definitely
glycogen hepatopathy as an entity and also causing cirrhosis, because like you said, there's no case described. I can still argue that could be NASH, and a lot of NASH, when they get cirrhosis, the fat disappears. It's quite common to see that, even in explants. So
we didn't see that much of nodular regeneration, nodules or this thing in this biopsy.
She has portal hypertension. Obviously, she has cirrhosis.
Portal hypertension can also sometimes reverse.
So my point is, there are a lot of assumptions being made. So we can't classify it as an entity and then you control sugar and then they just become less decompensated.
We need to look into that mainly because this entity is recognized. No,
I agree.
Entity is definitely recognized. There is a literature on that.
More as a early stage where there's enzyme elevation, and then you control sugar, some of them improve. That kind of literature you have.
No, the point is they came with decompensation. That is what is thing. So
it's interesting you picked this up, but I think we can't make too many assumptions based on one
we are not making an assumption, but at least there's a pathological diagnosis which probably what we need is, see, all these patients when treated became better. Otherwise, the first lady, I think, could have been pushed for a transplant or something like that.
Again, assumptions.
That's what I'm saying.
Yeah,
sir. This is the 3 cases which we just stumbled upon because of our pathologist. And we looked into it and it looks to be interesting, this one. Probably we should look more into this and see.
Which, sir?
You have done a lot of liver biopsies. Now, how many times have you seen this classical picture of a ghost cell where the glycogen is eaten in all your liver biopsies?
Very rare. I've never seen.
That's what. See, in NASH, definitely ballooning, Mallory-Denk bodies and all the thing.
I disagree from that point because I know Hema may add a lot of cirrhosis when you biopsy or you do explant liver histology. You don't see fat. But you make a
neither we see glycogen also.
No, I'm not saying
neither we see glycogen also.
You're assuming it is only glycogen hepatopathy that has caused cirrhosis.
This
this
hepatopathy can also lead to fibrosis. But since it has come up, we thought we'll just put it up across.
It's interesting, but he made a lot of assumptions saying this is this. You treat insulin, it will reverse. NAFLD won't reverse.
The assumptions are there in the literature. That's what we just we just had 3 cases and we thought we'll just
it's an interesting case, but I won't go beyond that.
Yeah.
You can't make it as an entity called hepatopathy causing cirrhosis. That's what I'm trying to say.
Okay, yeah. This is we'll publish it.
Okay. Thank you, sir.
Maybe. The message is, I'm again telling you, the message is, when unusual presentations, hypothyroidism, we were looking autoimmune liver disease. Pardon me?
Diabetic NAFLD should do biopsy.
No, I think if the presentation is slightly atypical and is a lady, we would rather do it because our thinking of doing on a lady for autoimmune is quite high. I think this is something which we picked up in my 25 years of experience, that we have found autoimmune in biopsy rather than your biochemistry.
Okay, thank you very much, sir. Our secretary is here, so okay. That was a very interesting case. So obviously, biopsy has to be done, so that was a good learning point. Glycogen in the liver, yeah, multiple questions are there. I will ask sir after the, after the session. And we'll go for the next case.
So for the next case, can I call upon Dr. Sneha from Miyot Hospital to present paraduodenal lesion?
Good evening, everyone, respected professors, teachers, and colleagues. I'll be presenting a case on paraduodenal lesion. A 38-year-old male residing in US, he presented with increased frequency of stools for a period of 2 weeks in 2019 from September end to October 1st week. He had about 2 to 3 episodes per day, which was clear, watery, not associated with pus, blood, or any nocturnal episodes. And he had no history of abdominal pain, vomiting, or jaundice, and no known comorbidities. Appetite and sleep were normal, and no significant family history. Examination findings were unremarkable, and even per abdomen was soft, vitals were stable. This is the timeline of the patient. A patient was initially evaluated in Coimbatore in October 2019. Then he was referred to us in Chennai in October 2019 for EUS. And after this, he underwent further evaluation in US in February 2020. The initial investigations which was done in October 2019, labs and stool routine was normal, and ultrasound abdomen showed a periduodenal lesion. And in PET CT, there was FDG uptake seen in like a paraduodenal lesion of about 2.7 into 2.7 lesion, and there was a paratracheal lesion as well, for which they did EBUS under general anesthesia, and which turned out to be benign. And even OGD scopy showed non-specific inflammation changes. After this, he was referred to us for EUS assessment. This is the EUS video. You can see the paraduodenal lesion, and over here this is the target lesion, which is a 2.5 into 2.5 centimeter hypoechoic lesion, and we have done FNAC from there. So the biopsy showed a well-differentiated neuroendocrine tumor with a low mitotic activity, and Ki67 index was not determined. And the immunohistochemistry stain was strongly positive for both chromogranin A and synaptophysin. So this was found to be a metastatic lymph node. But from here, at this juncture, we have to search where is the primary of this tumor. This is the HP which is showing the classical neuroendocrine cells with the nuclei showing the salt and pepper chromatin. And on the right side, you can see the chromogranin A stain. So after this, patient went back to US and he got further evaluation done there. He again repeated all the scopy, DOTA scan, PET scan, US, MRI, everything in search of the primary. And further after that, they've planned a surgery where they have done a diligent screening of the bowel and pancreas, which did not show the primary. And again, scopy was done, and there was no lesion noted in the duodenum, and the node, the lymph node was resected. And presuming the common location of these tumors in D1 region and the lymph node position, a duodenotomy was done, and grossly also there was nothing visible, but later a small outpouching was seen just distal to the pylorus, and when the stitch was applied, you can see a small, very small 4 mm nodule was noted, and the frozen section confirmed it as well-differentiated neuroendocrine grade 1 tumor. And along with this surgery, even prophylactic cholecystectomy was done, anticipating any further somatostatin analogs, which can have the risk of gallstones. So this is the pre-op and post-op values of the hormones chromogranin A and gastrin, and you can see that both of them have drastically reduced from 425 to 33 and 306 to 15. Now, a brief literature on the neuroendocrine tumors. In small intestinal cancer, we are seeing an increasing incidence, it's almost 40%, increasing incidence of NETs over the last year. And out of that, duodenal NETs, they form 1 to 3% of the primary duodenal tumor. Most are found in the D1, D2 region, and out of that, 90% are non-functional. Generally, they will be small and single in nature. If it is multiple, we will suspect Zollinger-Ellison syndrome, who will have even dyspepsia symptoms. But most of them are incidentally detected, many low-grade NETs. Now, how to go about the diagnosis of neuroendocrine tumor? So, the three categories, the histopathological examination is the key to it, where you see the stain, it takes up the stain for chromogranin and synaptophysin, and you assess the mitotic activity and Ki67 index. Then the biochemical markers, serum chromogranin and gastrin levels are measured, and urine 5-HIA, usually in midgut tumors which has the chance of producing carcinoid syndrome, are measured. And imaging is very important, and what we need to know is, along with FDG PET, even the DOTA PET scan, both are equally important, because few tumors take uptake in FDG and few don't take up. So this is an article where we are comparing the imaging sensitivity, specificity and accuracy of CT, PET and SPECT CT. So we can see that all FDG PET CT has more accuracy, sensitivity and specificity. This is a figure showing net PET grading. As I said before, some tumors will take up FDG and not the DOTA scan, and some will be negative for both and some will be positive for both. So it's important to know this, because based on this we can start the treatment option. If it is poorly differentiated and poorly differentiated and positive for both, we will tend to go towards like even chemotherapy, whereas it's well differentiated and grade 1 tumors, we'll start with surgical resection. So this is a table showing the different treatment modalities of well differentiated and poor differentiated tumors. So like I said, the functional imaging, the DOTA scan, where the somatostatin receptor is detected, that is positive in well differentiated tumor, whereas FDG uptake is more in poorly differentiated tumor. And based on the tumor differentiation, we will be treating the patient accordingly. So from this case, what the take-home messages we are learning is, some tumors can be metastatic at presentation, and the primary tumor can be very elusive and sub-centimeter in morphology. Sometimes it takes a long time to detect the primary tumor, and it may need even diligent small intestine manual palpation and even laparotomy over laparoscopy. And in this case, we have done a prophylactic cholecystectomy in anticipating giving somatostatin analogs. Now, in our hospital, over the last 1 year, from last August to this August, this is the total number of neuroendocrine tumors we have seen in our case. All of them were not managed in our department. Few were from surgical team and few were just referred for evaluation. So this is from the nuclear medicine department. We have collected the data. Out of that, there were 4 NETs in stomach, 6 in duodenum, 10 from pancreas, 4 in small intestine, 2 from rectum, and 1 was found to be metastatic in liver, where the primary was undiagnosed. So I would like to conclude by saying that you need very diligent evaluation and focused attention in evaluating a neuroendocrine tumor, and a team of members to come to a conclusion, because they can have varying presentation and heterogeneous presentation. Okay, thank you.
Any questions from the audience, please?
What's that?
Could this be a primary nodal gastrinoma? Because we are not able to get anywhere. The second thing is, if you had a K1 index at the outset, So if you have a neuroendocrine tumor and if your KI index is less than 10%, I think you should always do a PET Dotanac first.
Yes,
If
sir.
it is more than 10%, then a PET scan should be able to take it. Because he had some watery diarrhea going on for about 3 months, about
Yes.
3 years. So the other thing is, if you're not able to get anything, there is an entity called primary nodal gastrinoma. They can also present like that. Because at the moment, we have a patient in the hospital who had ulcerations, watery diarrhea, renal failure, and he's also got a paraduodenal lesion. At the moment, he's on anti-proliferative treatment. Once we cut ulcerations, so we thought we will probably do. Second thing is probably per-operative EUS, when you're doing it, could have picked up a small unit.
So this patient had only 3 weeks of diarrhea, and he flight back to Coimbatore, his native place. He got evaluated himself. Diarrhea stopped. That's what doctor was asking me. Diarrhea stopped on its own. So what LVK was asking me is whether this could be gastrinoma. It's possible. I think whether it's functional NET, possible. A non-functional NET, I think it's possible. We couldn't fix it. He had a diarrhea for 3 weeks, sudden onset, watery, no other complaints. Got evaluated. It stopped on its own even before treatment. So he got EUS done here. For some pressing reason, he had to fly back, where he was constantly in touch with us, because he was my known patient to one of my immediate senior in my college. The faculty there accepted it as NET, but they wanted to re-evaluate him, everything. Upper GI-scopy, colonoscopy, daughter PET, MRI scan to pick up liver mets, and then EUS also. Unfortunately, still primary was elusive. So then the treating faculty decided to go for surgery. A node was resected. Again, primary was elusive. So then I could read the surgical notes, which he texted me. The operating surgeon on table couldn't locate the primary. He decided to, this was operated in Stanford University. He called Dr. Norton. This I read from the discharge summary, who is an expert in NET. He has a huge experience as a surgeon towards endocrine tumors, particularly NET. He was called in, went to the theater, and then both of them decide that they do an intraop endoscopy. Up to D4, nothing was located. Given the location of the tumor, they decided for a duodenotomy. And he has written that initially they didn't notice anything. Then suddenly they noted a post-pyloric small outpouch, which they put a stitch, which threw a small nodule, which was returned as NET. So we present this for this rarity. And as for Dr. LVK was telling, this I believe that it's primary has been found out, no sir. So still, I don't think I think it could be a gastrinoma. But till now he's on follow-up with, on email communication. He's doing clinically well, undergoing clinical, biochemical and image evaluation. He's doing very well now. Either clinically, biochemically and imaging wise, he is fine.
Most of the primaromas are 90% out in the duodenum.
Yeah.
And most of them are submucosal. Most of them are less than 1 centimeter.
Yeah, sub centimeter.
Sometimes we need to keep on looking for it with intraoperative endoscopy or ultrasound. There are some times when you don't find anything and you don't have a pancreatic mass, or your PET Dotanac does not pick up anywhere else, you just do a duodenectomy and come back. If patient has got a very symptomatic gastrinoma symptoms, like he has repeated diarrhea or ulcerations. But only the chromogranin and this one does not fit into that gastrinoma. Your initial chromogranin
very high value expected. So I like to ask one question, sir. And here in our hospital data, we had one liver NET. He is on treatment. That case was a neuroendocrine carcinoma. But the K index was very low and he is doing well. Even today he came for follow-up NET, follow-up PET CT. He is doing very well. So how many cases of neuroendocrine carcinomas are surviving beyond 1 year? Because textbook says, literature says, if you diagnose neuroendocrine carcinoma, it's a verdict. Survival is not more than 9 months. That is one thing I want to ask. And for GI and pancreatic NET, I think we have to agree upon doing both DOTA as well FDG PET. Because there was a recent conference here under Dr. Ela's unit and I think even Jem also. They were all telling that both has to be done only if it is G2 and more. But I think we have to do both for even once we diagnose a NET.
Carcinoma or carcinoid?
Carcinomas, very poorly differentiated.
Carcinoma
gas level was mildly high, sir, mildly high. But actually they concluded, what Dr. LVK, what you asked was, but they have concluded on their discharge notes as gastrocnoma.
Clinically, it looks like that.
So that's what I said. I have points to argue it's functional, I have points to argue it's non-functional, sir. Because he had diarrhea, watery diarrhea, which stopped on his own. The diarrhea could be related to NET, but how it stopped on his own, I don't know, even before surgery. So whether it's really functional or non-functional, but patient is doing well. Incidental. No, it was, no. Diarrhea was when he was in the United States, when he was there. Then he came down here for evaluation.
But the node is big. It is 2.7.
Node is very big, sir.
I think that needs to come out. So this could be, I don't know, you may, that nodule would have been the primary.
Nodule was proven, sir. Biopsy.
The only way is that because it presented with diarrhea and all, so it could be a gastrinoma.
Possible.
But the only thing is the endoscopic findings were not there.
So that's what the endoscopy, I thought this question will arise. Because endoscopy was done in Coimbatore by us. As well, they did pre-op and intra-op also they have done. But nothing was seen, sir. But actually for gastrinoma, what the literature says is, it is a recurrent ulcer, refractory diarrhea. Nothing was there.
That's what we have one patient now. He's also got a big paraduodenal lesion. He's right now in the hospital. He has bled. When we did endoscopy, esophagus showed a lot of ulcerations. Stomach showed thickening of the stomach. Biopsy was for classical foveolar hyperplasia. Then he had ulcers from D1 to D4. And our PET showed 8 into 7 millimeters small lesion in the duodenum and a paraduodenal node. Biopsies consistently taken has shown only peptic duodenitis even from D4. So at the moment, what we have done is we have put him on high dose of octreotide now and 120 milligram pantoprazole. He seemed to be settling down now. Probably now we need, once the ulcers were too big. So now after he settles down, we thought we'll explore him, because the literature says that you give about 6 to 8 weeks of anti-proliferative treatment and then take them for a surgery. That small 8 into 7 is there in the third part of the duodenum. We did the biopsies from there, it has come only peptic duodenitis.
Okay.
But rest of things showed foveolar hyperplasia. His stomach is thickened, that showed foveolar. He's still in the hospital, he's refusing to go home. He's worried because he had 3 times bleed. And our CT angio did not pick up any this one.
Tumors. So what we want to highlight is the NET incidence is very much on the rise. And in this, our last 1 year data, 2 things what we have found out was, one patient had a synchronous, one adenocarcinoma and the sigmoid, for which an FDG was done, which showed a NET in the pancreas. That was one. And one liver case was still, he is on treatment for 2 years, primary is still elusive.
NET is still an enigma. I recently had a lady who I did the CT because I thought she had IBS and I could not complete the colonoscopy. But actually what she had was a 3 into 4 centimeters in the tail of the pancreas. I don't know, and most of them diarrheas were not very prominent in this patient. So she's going to undergo surgery.
I mean, NET, they say that the diagnostic delay is from 6 months to 9 years. 9 years. Literature says.
That neuroendocrine carcinoma, can you resect it off?
Which one, sir?
That one.
No. He underwent resection initially. I think Dr. Ilango has done. They have underwent a resection 2 years back. He's doing stable. Yeah. And now he has come today. I think they did it. Biopsies NECs, but still he's holding on for 3 years.
They do very well because if you have a single metastatic liver, it's always better to resect it off. Then later you decide where you want to put them on lanreotide every 3 weeks. And now they say if you have a metastatic neuroendocrine metastasis, and you have completely taken out the primary, you can even do a liver transplant in these patients.
Yeah, that's a new Milan criteria. NET Milan criteria. And I thought I will request Dr. Ubal also, we can have an NET registry for from our side.
Thank you, sir.
Any more doubts?
Any points from Dr. Jashwant? Surgical GE people are there. Okay. If there are no questions, we'll close this session. I thank all the speakers, Dr. Dinu Abhirami, Dr. Dhanush, Dr. Sneha. They did very well. Thank you.
Thank you, chairpersons. And we move on to the next session of my report. And we have 5 new members, one consultant from Naravi Hospital, Dr. Rabindranath, rest of them from PGs from Chettinadu, Dr. Rutaj, Besic Valentine, Anuj Arora, and Manjunath. And we have successfully completed our CRC study, which was initial analysis was done in last month meeting. We have also received the last set of data from, I think, from PSG. And again, a big thank you for all the participating centers. Dr. Ebi is busy in processing the manuscript, and soon we are publishing this, one of the largest study in India. So again, thanks to all the members who eagerly participated in the study. Our upcoming projects will be a Plex study. This is where initial performa is Dr. Alagame was given, and Dr. Epan is doing some modification. We are planning to have a first Zoom meet in the first week of November with a group of members. This is going to be a short-term study, and hope to start before this year end. And I already, Dr. LVK spoke about alcoholic liver disease study. Again, this is, we are planning to hopefully start by a month of January or February. And we have successfully conducted our midterm meeting in last month, and there are almost 145 to 150 participations. And we had Dr. Minnie and Mathan orations on liver disease and population health by Professor Abhijit Chaudhary. And the meeting was credited by Tamil Nadu Medical Council as well as MGR Medical University. The upcoming meeting, we have successfully completed our GF journal 2 years, and all the 8 issues were completed successfully. And we will having our second anniversary of GF in November 26th at ITC Chola. I think we also have an editorial board at that meeting. And year end, as usual, we have after case presentation, we have a TNAG Melodies on December 29th. ISGTNC Jaipur, all of you are aware, and January 5 to 8. And our annual meeting will be at Trichy from March 25 and 26. Please note down these dates and be present. And we have our rodenticide poisoning study was successfully taken over by government, and they were started Plex across 6 government setups. And we planned from the TNAG Society to give an annual award in our annual meeting for the best performing districts in Tamil Nadu. This will be given by a TA NHM program, and maybe we'll give 3 best performing districts for managing rodenticide poisoning in the usage of Plex. This is our last issue, and where we have a GF 4th issue, and there will be a review article as well as original articles, and all the last month's presentation also printed in our last journal, that midterm abstracts were presented. Thank you, and we move on to the next session. That first time we have thought of doing a journal club, because there are a lot of postgraduate members, and it's very, because the literature is so vast and very difficult to pinpoint which is a good journal and which is the bad one. And I request the chairpersons to come over the dais, Dr. Shankar, Dr. Kanagavel, and Dr. Jai Verghese and Piramanayagam, to carry over the session. Dr. Kanagavel will introduce the speaker. And
good evening, friends, senior professors, faculty, and my dear friends. It is a privilege to be with all of you, and I have been assigned the pleasant duty by the secretary to introduce the eminent speaker for the day, who is going to take through the journal club initiative of the TNISG program here. Dr. Sridhar Sundaram is a MD in internal medicine and DM in gastroenterology. Right now serves as an associate professor, Department of Digestive Diseases and Clinical Nutrition at the Tata Memorial Hospital. He is also serving as a consultant in the GI Disease Management Group, the TMH, and he leads the clinical program for the ERCP and endoscopic ultrasound. And earlier he has been serving as an assistant professor at the St. GS Medical College at KM Hospital, and he also serves as a visiting consultant in endoscopic intervention and endoscopic sonography at Bhai Jirbai Wadia Children's Hospital. A brilliant academician to have the crown of many of his awards. He is the WO International School of US alumnus, recipient of a very popular Japanese Society of Gastroenterology Research Fellowship, and he serves as a member of the ESGE Diversity and Equity Working Group, and he currently serves as the secretary for the Gastroenterology Research Society of the Mumbai, and he's also the prestigious winner of the International Digestive Disease Forum 2021 Best Video. And more so, he has been awarded one of the Best Biostatistics Program Fellowship by the NIH USA, and he has expressed very unique interest in systematic reviews and meta-analysis. And he also serves in the as co-editor of the Journal of GI Diseases, the E-World Gastroenterology News by the World Gastroenterology Association. I think much more is there. Let us go to the program. Over to you, Dr. Sridhar.
At the outset, I'd like to thank Dr. Ubal, Dr. Venkatkrishnan, and the TNISG for this opportunity. So, my talk today is slightly abstract. I'm going to talk about critical appraisal of literature. So, over the next 20 minutes, I will try and cover how to read literature. The talk was largely aimed at students. I'm sure a lot of senior gastroenterologists are here who've been doing this for years together. And if there are any questions in the middle of the talk, I wouldn't mind if you can stop me and you can ask at that time itself. So this is the overview of my talk. I'll be discussing is reading journal articles of any use, how to do critical appraisal of the article, and how to do critical appraisal of the research method. They are two separate things. And lastly, how to keep up with the wave of publications that's coming. So we all know traditional sources of information. Most students would depend on their Schlesinger textbook and would go to that for everything. Again, a large amount of the reading that we do is for review articles, but these are all narrative reviews. They are not systematic reviews. So they give opinionated takes on some topic. And of course, largely you receive a lot of product information from medical representatives. Now the issues here are, there is of course some inherent author bias. There are of course vested interests from the industry. And lastly, of course, the field of medicine is ever changing. Now Schlesinger comes once in every 6 years. So of course there are going to be a lot of articles that come in these 6 years, and you really need to keep up to change practice. So why evaluate research articles? Now, of course, there's a large amount of data available at our disposal. So the internet is, with the internet coming in, so there's a lot of data that is easily accessible to most of us. And clearly, we are not able to make a distinction, or different studies will give us different inferences, and we have to make the distinction whether one study is better than the other or not. Can anyone identify who this is for me? Anyone? I mean. So this is Ted Bundy. I don't know if you know Ted Bundy. Ted Bundy was, he's a good-looking man. Okay, so if you actually go by face value, he's a very good-looking man. He looks quite like a politician, but he is a serial killer who killed 30 women in the United States in the 1980s. So if you cannot take things by face value. Clearly, you need to go more into the depth of things before you're taking things by face value. That's not Einstein. That's his lawyer. So strangely, when I was downloading this photo, someone actually pointed it out. It might be Einstein behind him. So yeah. Again, of course, a large amount of research that we do is industry sponsored. So we really need to read into the depths of an article to decide whether an article is good or not. Of course, if you read articles, you will be able to write letters. It will increase the number of publications you have. It will also give you a sense of becoming a critique over a period of time, and you will improve at it. And lastly, of course, it's great fun to actually review articles and read articles. So is it really necessary to appraise literature? So a lot of people think there has to be some amount of aptitude. You should have the skill, the aptitude to actually go into research or read research. But that's really not the case, to be very frank. If you've reached till DNB or DM, the fact is you have the knowledge and the works in your brain to actually read literature and to critically appraise it. Now, if you do not do it, what is the issue? Now, the problem is that you technically know nothing in the beginning. You just depend largely on your textbook. You're not able to keep up. But your confidence is very, very high. And that's where you will reach the peak of Mount Stupid. And eventually, once you start reading, you realize that there is so much more to learn. And that is where the enlightenment will actually come. So it is really necessary to appraise literature and keep up with the pace of publications that is coming. So what literature should one actually read? There are different types of papers that are published every day. So high impact journals publishing quality research is what most people would go to. You'll be reading maybe gastroenterology, hepatology, or Journal of Hepatology. They are good journals, and you'll be going to them for research. Again, what is likely to impact your clinical practice? I'm sure that some translational research is not really going to change your clinical practice overnight. So maybe you will not really go into that. Again, you might have some areas of interest. For those who are into motility, you might read JNM or neurogastroenterology motility. So of course you can read that. And lastly, of course, journals publishing articles from your region, research from your region, are something that you should be looking at. So the Indian Journal of Gastroenterology, or the INASL journal, JCEH, or even the SGEI journal, JD, is something that you should be looking at, because it is data published from your own region that you should be reading. So I'll be going on to critical appraisal of literature. There are two aspects here. One is, of course, critical appraisal of the article and appraisal of the research. So we'll go first to the article. So of course, there are contents in every article. Every article will have a title, abstract, the IMRAD format, which is the introduction, method, results, and discussion, references, and language. So we'll be discussing the same. So of course, title is critical. You know, people are usually sheep. We usually look at the article and we get swayed. And we will, of course, science is all about marketing at the end of the day. So you will read the article and you might get swayed and you might read the content inside it. So you can see some catchy titles coming on PubMed also of late. But what are the critical things in a title? Now, often if the title is very long, the human brain would presume that there are more authors, there is longer text, and automatically the number of citations will reduce. Again, if the title has low readability, if it's a strange title, there is a lot of confusing words in the title, you feel that the science may be much higher than what you can actually perceive. If there's humor in the title, it's often amusing. It will, of course, you would automatically tend to question the author's credibility. And of course, there are two types of title. It can be a question title. Question title issue is that it gets fewer reads and is cited less. On the other hand, if it's a descriptive title, often and on titles which already tell you the result in the title itself are read more and of course cited more. So, but the point is, you should not be going by the title itself. You need to read more into the depth. At least try and read the abstract, if not the entire article. Now, of course, the introduction, it should describe the current stage of knowledge, enlist the gaps, try to show why we need to conduct the study, and lastly, of course, provide the rationale and the aim. Now, the aim is often defined by, in comparative studies, by PICO, wherein you have a population, intervention, comparator, and outcome. So you usually state a primary hypothesis. In this case, it's drug X versus drug Y in serotics to improve survival. So you have the population, which is serotics, drug X being the intervention, drug Y being the comparator, and survival being the outcome. So this is usually how you would look at a name, and how you will read a name whenever you're reading a journal article. So if a paper comes to you for review and the aim is not written in this format, you would automatically want to see why it is not written in that format, and you might ask the authors to write it in that format. Again, methods, this is pretty much the most critical part of any study. I'm going to be coming to this in details, but usually describe what has been done and who is part of the study. That in the sense, it's not just the participants in the study, the participants and those who are actually conducting the study both have to be described in detail. What did the investigators look for and how was it done? And lastly, of course, the ethical considerations, which are very critical now. Every journal would want ethical considerations to be on top. So whenever you're reviewing research, maybe you should also look if that is mentioned anywhere. Again, coming to results, how many were screened, how many were found eligible for participation, how many completed the study, lack of completion, figures, gaps, discrepancies, and of course, most importantly, the statistical analysis. Now, often and on, we just presume p-values are good enough, but sometimes you need to go into the depth and see, because the p-value may be less than 0.0001, but if you actually look at the confidence interval, it would be a wide confidence interval. So just don't go by p-values, also look at the confidence interval. Statistical analysis is a different topic, I won't be going into that, but nevertheless, make sure that you always check the statistics. And lastly, of course, coming to the discussion. Now, it has to summarize the key findings in the study first, then it has to compare it with previously published evidence and say why it is different, show the strength and limitations of any study, what new evidence does it bring to the table, and of course, interpretation of the study in the totality of practice and how it's going to change practice and research for the future. So all of this has to be mentioned in short in the discussion. So whenever you're reviewing a paper, all of these should be there. Now, language is quite an issue. Okay, so I know that all of us do not inherently speak English. My mother tongue is Tamil. I'm sure a lot of people here did not learn English as their primary language. So it's often difficult to, for authors who are non-English to write English, and which is why often there is misinterpretation that is seen in the papers itself. Something might be written and it might be taken out of context. So always try to read the paper well and see and take it in context. If there is a question, please ask, write a letter to the editor, and you might get an answer as to what the problem was. Now coming to appraisal of the research. Now this is more critical. Now, is the research done properly? Of course, the research question, the design, the study settings, methods, all of that. And of course, are the research findings applicable to my patients and how do I use them? So coming to the research question. Now, this is a meta-analysis published in BMJ in 2003. Now they try to check if parachute use was good enough to prevent death and major trauma related to gravitational challenge. Now, of course, they did not identify any RCTs in this systematic review. In the end, they wrote, under exceptional circumstances, you apply common sense. I would suggest not just under exceptional circumstances, on routine, in your routine practice also, please apply common sense and do not read articles that are, of course, stating the obvious. Now, of course, research articles often go by these things. The research question has to be feasible, interesting, novel, ethical, and relevant, and that's how you would also screen your research articles. Now, Professor B.S. Ramakrishna also added these two things. So I give him the credit that he also added that it has to be simple and clear. So these criteria are something that you're looking at when you're looking at the research question. And what about the participants? So of course, there is a target population on which the study is intended, and they are clearly, explicitly defined by the inclusion and exclusion. So in every study, you would have to look at both the inclusion and the exclusion, and how they are sampled. Now, consecutive sampling would be people coming in, and let's say I have a trial on acute pancreatitis. Every patient of acute pancreatitis, I will try and screen. So that's consecutive sampling. Now, stratified sampling, on the other hand, would be based on some subgroups. Let's say I want to try a drug in patient of HCC with cirrhosis. I have child A and child B, so I'll stratify the drug at different doses in child A and different doses in child B. And of course, there is convenience sampling that is largely for population studies. Let's say I want to check sugars for the entire population. This is a convenience sample. I can see that all of you are gathered here, so I can just check the sugars for everyone and see how many are diabetics, let's say. So you have to really look at this when you're reading the study. Now, of course, sample size, often, although it's mandatory, it's pretty mystical. Not a lot of studies will actually mention how they have done the sample size. You would see the entire study and no one would actually know how the sample size was calculated. So it's based on the null and the alternative hypothesis of the basic research question. Often you will have to wonder, a lot of centers will publish research with a lot of patients, but you might want to ask, is this sample size feasible? Okay, a lot of people will publish a lot of data with a lot of patients, but it has to always be asked. Again, the sample size will depend on the kind of design you have. It might be superiority, wherein you're saying X is superior to Y. Non-inferiority, meaning X is not inferior to Y, but may be superior. And equivalence would be X is equal to Y no matter what. And lastly, of course, there is that question of whether underpowered trials should be accepted. Often the research fraternity would often say that underpowered trials are not good, it's a problem. But remember that underpowered trials may give negative results, and negative results often do not get published. So there is a clear file drawer problem wherein you won't know that there are negative results. So we need to have these underpowered trials also coming into literature. So you might have to go back to clinical trials and see. Now, outcome measures are often required to be clearly stated in every study. So whenever you're reading a paper, you should see if the outcome is mentioned. So there can be the primary outcome, which is the outcome of greatest interest, used as the basis of the trial hypothesis. There can be secondary outcome. And lastly, of course, there can be exploratory outcomes. Exploratory outcomes are something that you found in the study and you feel that it might be of use for future research. So let's see this as an example. Now, this is a published study by Dr. Sham's group in GIE in 2018. And so in the methods, they've clearly stated that the primary endpoint was the rate of adverse events. The secondary endpoints they've clearly stated. But if you actually go down in the results, they've actually talked about these endoscopic interventions, ERCP or EUSBD, impeding surgery, impeding pancreatic duodenectomy. So that's an exploratory outcome. They've actually talked about surgery being impeded by one of these procedures. So that's an exploratory outcome, and that is also something that you should read, and you should I mean, you can take that as a research question for your studies. Now, there can be different types of outcome measures. There can be a clinical outcome measure wherein you feel that the ascites in a patient has resolved after X drug versus Y drug. Patient-reported outcome like pain in chronic pancreatitis. Patient-reported outcome measure wherein pain in chronic pancreatitis on the ISBK pain scale. Hospital or process-related outcome in the sense how days of hospitalization, resource use measure like the amount of blood that was used for a surgery, and of course surrogate outcome measures. A lot of studies will actually use this surrogate outcome measure, and that's a problem. You might use CRP as a marker for IBD, and you have to really read closely into the text to see that they've written that the IBD actually resolved, and what they were actually doing was measuring the CRP and saying that the IBD actually resolved, right? So you really need to look at the text in detail. So basically issues is that there is lack of standardization which leads to bias, and clearly there are new initiatives now. So you can actually check out this initiative if you're ever writing your protocols, because this is a good initiative. It gives a list of fixed outcomes that you can use for your studies. The study design, we all know this pyramid. So of course, the top of the pyramid is the filtered data, systematic review and meta-analysis. They are said to be the best available research. And of course, below that come the randomized control trials, which are again the best in the unfiltered ones. And of course, below that come the others, the case control, the cohort studies and all, so on and so forth. But again, even though this pyramid exists, there is a lot of issues in each of these, and I'll come to each of them in detail. Now, there is a certain way every study has to be reported. So there is the Equator network, which actually looks at how studies are done and how they are reported. And there is a way of reporting them. So there is a STROBE guidelines for observational studies, CONSORT for RCTs, and PRISMA for meta-analysis. So whenever you're reviewing a paper, you should always look whether this has been followed or not. Now coming to observational studies, there are different types. There can be cross-sectional, there can be a prospective cohort, retrospective cohort, or a case control. Now clearly they need less time and resources. There are less ethical concerns because a large number of them would actually be retrospective. With, even if there's a harmful exposure, you're really not worried. Now, usually they are very useful when the outcome of interest is very rare. But the problem is it's less valid, it's difficult to establish causality, and of course there's an inherent risk of bias. Now what most authors these days try to do is try to match. They try to do a propensity score matching to get matching into an observational study and show that it is similar to an RCT. And you will read a lot of papers coming in now talking about propensity matching. So there are, of course, certain advantages. You're trying to remove the confounders, but there are disadvantages. It's time consuming to do this, of course, statistically. Again, the decision to match the variables, you're choosing the variables. So you can choose variables which you feel should be excluded. So again, that is a bias. So it requires a matched analysis. And of course, sometimes you might overmatch, and you might actually do overmatching and you might not find a significance at all. Now, of course, coming next to RCTs, this is the top tier in experimental study design. So the cornerstone is randomization. It has to be it ensures balance. It has to be unpredictable. So clearly, we don't know which group the patient would get assigned to. Now, blinding is often done in studies. So you really need to look at blinding, because if blinding is not done, there is likely to be bias. Open label studies will have bias. Single blind would only be the patient is blinded. Double blind would mean patient and the investigator is blinded. And of course, assessors may be blinded in a triple blind study. So blinding is essential. You need to look if the study is writing about blinding. Allocation concealment is different from blinding. It basically means that the investigator doesn't know which intervention the next patient is likely to be allotted. So if you're doing block randomization, if I have blocks of 4, I'll know that the next patient is likely to be allotted the X drug. The thing is, allocation concealment is essential in an RCT, and it has to be mentioned in the methods how they've ensured allocation concealment. And lastly, of course, there has to be some quality control. There has to be some interim analysis, and there has to be some data safety monitoring. Interim analysis for both safety and efficacy. If the efficacy is overwhelmingly proved in an interim analysis, I don't see why we should be continuing the study. And if there are significant safety concerns right in the beginning, then maybe you should not really be continuing the study. A lot of studies use these kind of analysis. There's something called the intention to treat and the per protocol analysis. Okay, so intention to treat would be as randomized. So even if the patient has not really received the intervention, they will consider that the patient is part of that group and use them in the statistical analysis, while per protocol would mean only patients who actually completed the intervention and follow-up you're including. So of course, per protocol is more strict. It follows study guidelines. It doesn't actually, so it doesn't represent real world scenarios. But in usually, intention to treat will underestimate the superiority effect of the intervention. On the other hand, the per protocol may actually exaggerate it. So often studies will choose one over the other as to get whatever result they want. So you really need to read into which result they're getting based on this analysis also. Now issues with, again, RCTs would be inclusion and exclusion is tailored to the outcome. Sample size may not always be defined. There might be inappropriate randomization and blinding. And of course, there can be study co-interventions. Now let's suppose I'm doing a trial on biologics in Crohn's disease. Diet may be a factor. So, and we are not really accounted for that at all. So study co-interventions have to be defined and you need to check when you're reading the article. So let's suppose this is an RCT. Again, this is an RCT published again in the BMJ. Now from that meta-analysis, they actually said we'll do the RCT. This is in 2018 that they published this. Parachute used to prevent death and major trauma when jumping from an aircraft. And this is a randomized control trial. They said they had 92 passengers who they screened and 23 agreed to be enrolled and randomized. Now, if you actually look at details, parachute use did not significantly reduce death or major injury. 0% for parachute, 0% for control. But if you actually go into the depths, you'll find that compared with individual screen but not enrolled participants were on aircraft at significantly lower altitude. That means 0.6 meters, which is basically ground level, versus 9,100 meters for those who did not want to be included in the trial. So clearly, you need to read the subtext always carefully before interpreting. Okay, last, coming to systematic review meta-analysis. Now, there are multiple things that you do in a systematic review and meta-analysis. There's a research question. They try to define inclusion, exclusion. They search the literature. They select studies, assess study quality, and lastly, of course, extract data from all of these studies. Now, the critical step here would be to define the inclusion, exclusion, and to search the literature. Often, if you actually look at a systematic review, these are the places where they falter. If they have searched only one, let's say, database, let's say they've only searched Medline, then that's not a systematic review. They've not searched other databases like Embase, okay, or Cochrane. So you have to really go for all of that. Again, there are different models that they use. There's something called the fixed effect model and the random effect model that you will often see in meta-analysis. But I would just say that random effect model is better than the fixed effect model because it presumes that eventually for an answer for, let's say, for a value of a mean in a population, the random effect model will give you a range and the fixed effect model will presume there's a single value. So clearly the fixed effect model is really restrictive. It presumes that the population is not heterogeneous and that is where it can be used. So always you have to see that a random effect model has been used in a meta-analysis. Fixed effect can only be used if the heterogeneity is very, very less. Now, there are some cautions while interpreting forest plots. I'll just finish 2-3 slides more. So whenever there is stuff like this, you should not be jumping to conclusions without looking at the context and perspective carefully. Now this was again a comparison for eczema on immunotherapy versus control. And you'll see that in this side, it said favor immunotherapy and here favors control. On the other, in the very next table, this is 1.1, this is 1.2. On the left, there is favors control, here favor immunotherapy. So if you read it fast, you might actually presume the other way around. So you have to be careful as to what you're reading. Again, do not lose sight of what data is not there in the meta-analysis. Now, this is a Cochrane review. I mean, they are all said to be great reviews. But if you actually look at it, this is, I don't think you can see it clearly here, but this is a Cochrane review. They screened 2,500 studies. They included 43 in the qualitative synthesis, but in the quantitative synthesis, they've only included 7. And the outcome measure of interest, there are only 2 studies that have reported. And this is a meta-analysis published in Cochrane. So please read carefully as to what you're reading. Again, you have to see if the studies are very different to do a meta-analysis. If this I-square is more than 70-80%, they are not good to do a meta-analysis. So always read that also. Check if one of the studies carries most of the weight. Now this is a study comparing different types of depot preparations for contraception. And you will actually see that the Women's Health Initiative from study from Australia had 96% of the entire weight in the meta-analysis. Did they really need to do this meta-analysis is a big question. Because if this is 96% and the other are 4%, I mean, it's strange. So you really did not need the meta-analysis. Okay, size may not be everything. Again, I talked about size previously, but the size may not be everything. Quality also matters. Now, this was again a meta-analysis of different trials on, comparing blinded review versus open review for articles. And they actually looked at different studies and they found that eventually the meta-analysis said that, most authors would prefer an open review process rather than a blinded review process. Now, if you actually look at the quality here, the one with the least amount of weight actually has the best quality. This is a good study. This has a large amount of weight, but again, not good quality. So again, in a meta-analysis, there is always mention of publication bias in the end. There's a table with this green dot, yellow dot, and red dot. Please read that. So again, pitfalls of a systematic review. Now, usually you feel that it's a safer starting point than a single study. But it's always not reliable, so you have to be reading carefully. Again, a meta-analysis is a snapshot in time. Now, I can publish a meta-analysis tomorrow, and the day after, there'll be a new RCT that is coming on the same topic, and my meta-analysis becomes moot. So you have to be careful. Again, look carefully before you take an outcome literally. It might not be what it appears. Not all studies belong together if there's a lot of heterogeneity. Again, missing data and missing studies may torpedo a meta-analysis. So often, the file drawer problem like I talked about, negative studies are not published, and which is why meta-analysis may not actually represent what they are supposed to represent. And of course, the statistical approach. There are almost 12 to 14 different types of meta-analysis. Now, the statistical approach may actually change the end result significantly. Last slide, how to keep up with the publication wave that actually is coming. Now, there are almost close to 7 million publications that are published every year in PubMed. 7 million. I couldn't believe the number when I searched for it. So clearly, the most neglected task is often the most important task. That is how to keep up. So what you can do? Okay, dedicate 1 hour a week somehow into at least screening the abstracts, if not reading the entire paper. And then maybe if you actually read a paper and you feel it is significant, then maybe you go into the details. There are a lot of apps available now. I think everyone has smartphones. So QXMD has this read app, which is very good. It lets you follow journal articles, gives you updates on the topics that you're interested in. So you can actually use these apps. Again, social media. Now, a lot of people will think that if you go onto social media, you get distracted, but there are ways to tailor that. Now, what I do is that I've tailored all my social media feeds to include largely academic material. So if I open Facebook, I'll find gastroenterology, clinical gastroenterology, hepatology, gut, all of that coming first. And in Twitter, I follow those. So, while you're whiling away time, maybe use it for something useful also simultaneously. And lastly, of course, there are webinars that are available now. We ourselves conduct this month an endoscopy webinar every month. So I think you can attend those webinars and you can, of course, stay in touch. So lastly, my acknowledgements. Professor Bowdekar and Professor Nitya Gokte and Professor Shobna Bhatia, all of them helped me, not just with the slides, but also trained me in all of this. So a big thank you to all of them. Thank you.
Thank you very much for giving a bird's eye view of what is happening around and making sense of systematic reviews and meta-analysis. I think if there are any comments from my co-chairpersons or from the floor.
Thank you. It was a really nice talk. So however old you are, we always learn something. So it was nice to hear you. I just wanted to ask your opinion on this. We always value RCT as the gold standard, especially when you're comparing therapy or drugs compared to a meta-analysis. In your thing, you put meta-analysis as a number one, maybe for a different reason, like you mentioned, there are two different groups. But if you have a RCT that clearly answers something, then is a meta-analysis really going to add something?
So if there are multiple RCTs on the same topic?
Just say one good one, multi-center, blinded.
Yeah, of course,
sometimes they differ. Why I'm asking is sometimes you get a RCT saying something, and then several years down the line you get a meta-analysis saying something else. And in the meta-analysis, they'll include studies which are not as well conducted as the RCT, which skews the report.
So why systematic reviews and meta-analysis are rated higher there are two reasons. One, of course, it tries to give a composite data of if there are multiple studies on a particular topic. Two, it often gives a real world representation of what is actually going on. So if I have an observational study on the same topic, it can actually, that data can also be added into the systematic review and meta-analysis, and eventually you can come to a conclusion based on both combined together. So, which is why they are often rated higher.
And one more on the same theme. Supposing you don't have a good study to answer a point, you have several not so good studies, and then a meta-analysis comes and says something conclusive. Can you take that as a good value?
So it depends on the number of studies in the meta-analysis. So often you will see that a lot of journals, good journals also publish meta-analysis with 4 studies, 3 studies. So like I said, it's difficult to take this at face value. You need something more before we're able to draw a conclusion. So I would say, of course, not take it at face value. Yeah. I think I've given 3 journal articles to 3 students. They are 3 different study designs, and I've asked them to critique. They are all journal articles from October 2022. So I think first I'll have Dr. Sadguna to come. Yeah.
Good evening, respected teachers and my colleagues. This is the General Club. My name is Dr. Sadgun Rao. I'm an MG registrar from Apollo Hospitals, Chennai. And the topic given to me is motorized spiral enteroscopy versus double balloon enteroscopy, which was done by Weber Chan et al. In Singapore General Hospital, which was accepted on September 23rd in gastrointestinal endoscopy. There was no grant support for this study, and the conflict of interest was Dr. Ravishankar Ashok Kumar, who is a participant of this study, was a consultant of Apollo Endosurgery, USA. Regarding introduction, since its initial description by Yamamoto et al. In 2001, DBE has been the gold standard for the device-associated assisted enteroscopy than other options like SBE, like single balloon enteroscopy and spiral enteroscopy, though it required longer training and good assistance. MSc appears to be promising as the learning curve is shallow and good technical success, which was demonstrated by the Baina et al. Previously. However, there are no comparative studies examining the performance of MSc with the gold standard DBE. The aim of this study is to compare the diagnostic yield, therapeutic success, and complication rates between the MSc and DBE. Study design, this is a case-matched cohort study. They have reviewed hospital records from 2014 Jan to 2022 Jan. These patients were matched using propensity score matching. They have taken variables like age, sex, BMI, and ASA scores, and they have matched 1:2 of MSc with DBE. And after matching, they got 31 patients who underwent MSc and 62 patients who underwent DBE. The standard mean difference of the propensity score after matching reduced from -1.2 to -0.02. They included more than 18 years of age patients with suspected small bowel pathology on radio imaging or capsule endoscopy with written informed consent. They excluded the patient with comorbidities who are unfit for undergoing anesthetic procedures or sedation, pregnancy, and coagulopathy with INR more than or equal to 2.0 and platelets less than 50,000, severe GI tract inflammation or prior implantable devices in the GI tract, known or suspected bowel obstruction like esophageal stricture, Schatzkiring, stricture in the colon or ileocecal wall, perforation of the GI tract. All the endoscopists were experienced in DBE till 2019, so they were trained with the MSc with models and then animal models and also manicures, and then they have taken for the MSc. From 2019 they have used mostly MSc, but they used DBE only when MSc was unavailable at that point of time or the patient was unsuitable. So which patients were unsuitable were limited mouth opening and contraindication to the neck extension, because they didn't dilate the cricopharyngeal region, they just extended the neck and did the MSc, and prior esophageal surgery with narrowed esophageal lumen or severe esophagitis including diagnosed or untreated eosinophilic esophagitis and severe radiation enteritis and feeding jejunostomy less than 2 weeks and anal stenosis. These they have excluded for MSc and they have included into the DBE. And they have taken more precautions for MSc in patients with prior abdominal or pelvic surgery including altered anatomy and history of dysphagia or known esophageal motility disorder, mild to moderate inflammation of the colon. So DBE, they have taken two types of scopes, one with working length of 152 centimeters and other is 200 centimeters. And the over tubes were made of latex with overall length of 105 centimeters and 145 centimeters. So all the DBEs were performed under sedation or GA based on the patient profile. MSc, the working length was 168 centimeters and the working channel was 3.2 millimeters. For the antegrade MSc, they have done all the patients under GA with airway protection, but for the retrograde MSc, they have taken the options like sedation or GA. And these initially they have collected the data of 121 patients, but after propensity score matching, they got 93 patients, which was matched 1:2 with age, ethnicity, BMI, smoking, ASA, and included previously undergone JA surgery with altered anatomy and positive imaging before the enteroscopy. So outcomes, they have taken a primary outcome being technical and diagnostic success. Technical success they defined as passing the scope beyond the ample of water in the antegrade enteroscopy and passing of the scope beyond the ileocecal wall in the retrograde enteroscopy. And the secondary outcomes were therapeutic success. And the second primary outcome is diagnostic success when they are able to find a accurate diagnosis which was mentioned or which was not mentioned in the previous capsule endoscopy or imaging. And secondary outcomes were therapeutic success when they are able to treat like a bleeding or polypectomy or when there was a foreign body to remove it, and the complication rates. And these are the results of the study. So the purpose of enteroscopy, for the diagnostic purpose there was a difference, like MSc was more preferred compared to the DBE, which was significant value, but I don't know in the results whether we can take it. These orange lines, this is important. Orange lines and green lines, I mentioned it because these orange values were which are comparable to the previous studies. Like the technical success, which was equal in both, like DB and MSc, which was comparable to the previous studies by Baina et al. And also previous non-motorized spiral enteroscopy also. So both DBE and MSc, technical success both antegrade and retrograde was almost similar. There was no statistically significant difference. Along with that, a previous study showed that the total procedure time and maximal insertion time, that spiral enteroscopy has taken a lesser time compared to the DBE. But in this study, they showed that retrograde, the spiral enteroscopy has taken lesser time compared to the DBE, but in antegrade, the DBE has taken lesser time compared to the MSc. So they are both in maximal insertion time and also total procedure time. But they told that this might be because they have done MSc, they could get a maximum insertion of the depth, though they did not measure the insertion of the depth, that was the limitation, but they told that they could have achieved more insertion of the depth with the MSc, that's why the procedure time has increased. And overall diagnostic success and therapeutic success in a matched population was almost similar for the DB and MSc. Regarding the complications, according to Clavin-Dindo classification, the major was grade 3, 4, 5, and minor ones were grade 1 and 2. So DB did not have any major complications, but the MSc has one single, during the retrograde enteroscopy, there was a ileal perforation which required surgery. And in minor complications, though it was, the number was like 25% of the patients undergoing MSc had minor complication, which was comparable to the Ramchandran et al. From AAG. They told that about 25% of all the people who are undergoing MSc had the minor complications like erosions and also a throat discomfort. It is comparable to that. They had, out of those 8 patients which I was showing, 6 patients had grade 1, only superficial lacerations. The rest of the 2 patients has a deep lacerations. In those patients, the spiral scope was stuck in the upper esophagus. They could not propel it, unplate it. So they need to manually little bit use force to remove that scope. And these patients required admission, only analgesia, 1 to 2 days of admission and no intervention for that. It was spontaneously resolved. So the strengths of this study, it was the first to compare the outcome of MSc to the standard of care DBE, included both antegrade and retrograde, performed both diagnostic and therapeutic purposes and included post-surgical altered anatomy patients also. The limitations are mainly regarding the design. It's a retrospective design, so they have taken 4 propensity score matching variables like age and ASS score, BMI, but they have no underpower for the subgroup analysis based on the surgical anatomy or type of therapy, and did not measure the insertion of the depth, but they assumed that the MSc MSc has taken more time because of the increased insertion of the depth, though some other studies, even some randomized control trials, told that the insertion of the depth can be estimated. And all the procedures were done by experienced team, and it is a single center study. So whether the learning curve might have been easier for them, but in the real world, whether the newcomers, it will be the complication rate and everything will be the same or not, we are not sure. Conclusion: in patients requiring enteroscopy, the diagnostic and therapeutic performance of MSc is similar to DBE. Increased frequency of adverse events was observed with MSc. There are some restrictions in the indication because of the design of the MSc. Thank you.
Good presentation, Sadguna, but I just have a question. I mean, what do you think this study has added? When Sir had presented, right? See, when you review this article, right, you have been asked to review this article. So what do you think this study has added to the existing literature? What is new? Or would you, if you were a editor of a journal, it was submitted to you, so what would be your thought process?
Editor, sir. So I think.
I mean, that is why we review, right? Suppose it was asked, suppose it is submitted to you as an editor, like forget it. I mean, it's not about publishing, but I'm just asking, like, how has it improved the knowledge? Has it fixed any knowledge gap?
Yes, sir. My knowledge gap, it has filled.
That's okay. Good.
So actually, how to read a retrospective study design and how to comment on that. And second thing, what are the problems with matching? Though they say that matching can decrease the confounders, and this study being a bigger study with 121 people they have taken, still there are a lot of caveats in this. Not only because of the design and the methods and the unanswered questions in their same article itself, like they have taken they have matched properly by taking their own variables, like they have taken like age, matching BMI and everything, but they have good population, but it was underpowered to have a proper analysis, subgroup analysis later. So how to reduce this thing in a retrospective design, I'm not sure, sir. So maybe only a prospective study with randomization might help it. So the other thing is, analyzing this, I had little bit new things, sir. So 2 things we need to take from this, I think, sir. One is like whether we can change already experienced endoscopists, whether they can change from the double barrel endoscopy to the spiral endoscopy. As a trainee, whether I need to learn initially double barrel endoscopy or motor spiral endoscopy. So these 2 things I need to look when I am studying this study. So first thing, as an experienced endoscopist, whether they can go from DBU to MSc, this has answered, yes, they can go. When they're taking a chance of a little bit of adverse events and explaining them. But as a trainee, this hasn't answered the question, because I don't know whether the complication rates will be high in my hands in a new center after 1 year of experience, and whether the DB should I go back. This study hasn't answered that question.
Okay. Are you happy with the primary outcome measure that they, like what was told to you, like you look at the patient, the PICO chart, right? The patient, the intervention, comparator group, and the outcome measure.
Technical success as a primary outcome, they kept that I'm not happy, sir. Diagnostic success, I am happy, sir.
What would you like that technical success to be?
Technical success, just crossing the ample of water and retrogradely proximal to ileocecal valve. I don't think that should
is
be
the most
kept as the
important
primary.
thing. What we would have been interested to know is to see whether they did a complete small bowel
Complete
evaluation.
small bowel evaluation. That they did not address.
That is what is most important or most interesting or
And
be
they also
valuable for
clearly
an
mentioned that
endoscopist.
when they found what was required in the imaging, like in Crohn's there was an ulcer, or in a small bowel thing there was a bleed. After that they stopped the mortal spinal endoscopy and they came back. So they couldn't, it was not that they are doing the entire small bowel evaluation, so they could not compare the proper strength of each instrument in a both experienced and non-experienced hands. That we cannot presume that this is good or this is bad.
Sure. Good.
This is to Dr. Sridhar Sundaram actually. See, whenever we are doing that, the retrospective analysis, not particular this study, I am talking in general, suppose to compare the two variables, that time the propensity matching is the better one to go ahead, or any other study, I mean methodology is there for the better acceptance of the papers.
So there are different types of matching that can be done. So propensity score is one of the methods that can be used to match in a retrospective study. Now again, matching is never accurate. Even the propensity scores that we get after matching, there is a range of scores, and again, if there is a way to calculate if there is a significant difference or not in that. So again, if you take in this score, now they've taken a range of scores from -1.2 to -0.02. Now that's a big range. So in that again, they will look at the variance in the score, and if they fall in that 95% interval, only then will they be actually considered. So propensity score matching can be done, but it is not very accurate. So in an RCT, of course, the whole system is controlled, so it's pretty much the best design. Propensity score matching is trying to account for something similar to an RCT in a retrospective manner, but it's not going to be as accurate as an RCT ever.
Thank you. Thank you.
So thinking aloud, thinking about a meta-analysis, say the BOSS database or the Swedish obesity database or the NSQIP registries, which has uniquely big numbers like accumulated over a period of years, head-on comparison with a registry outcome and a meta-analysis outcome. Like, does it mean the registry outcomes are much superior because which so much of heterogeneity in the analytical stuff happening around?
Yeah. So I think we're comparing apples and oranges here. So registry data will have a particular, I mean, of course, both will have outcomes of interest that we are studying in a population. Meta-analysis will look at an outcome of interest in multiple different populations. In registry data, you will have one population and you're looking at data from that particular population itself. Now, let's say I'm doing a meta-analysis on different rates of, let's say, post-ERCP pancreatitis in trainees versus non-trainees. Now, the rates are likely to differ in different countries of the world. Now, if I have ERCP registry data only from the US, wherein they have a certain set of rules, that may be representative of the US. It's a good data, but at the end of the day, meta-analysis will give us a picture of the entire world altogether. So that's the difference here. But yeah, for your population, let's say I have an Indian registry and I'm looking at it, looking at registry data from India, that is what is relevant to me. Maybe it's not, the systematic review is not relevant to me. So that's a question that you need to ask yourself. We have Dr. Anupama from MMC for the next presentation. So she'll be presenting an RCT with a different design. So.
Good evening, everyone. The journal I'm going to be presenting today is Aggressive or Moderate Fluid Resuscitation in Acute Pancreatitis, which was published in New England Journal of Medicine. It was published on September 15, 2022. It was an open label, multi-center randomized control trial, and place of study was Spain, and duration of study was May 2020 to September 2021. Authors were E.D. Madaria et al. Coming to a brief introduction on the topic, moderately severe or severe disease develops in approximately 35% of patients with acute pancreatitis, a situation that is usually associated with worse outcomes. It is observed that regional hypoperfusion of the pancreas is correlated with necrosis. So, early aggressive fluid resuscitation is considered beneficial due to theoretical improvement in pancreatic perfusion. Nevertheless, subsequent studies have shown that administration of greater volume of fluid resuscitation during the first 24 hours may not improve outcomes. There were randomized control trials on this regard, and evidence from that is scarce because of maybe small sample sizes of the patient or flawed designs. A systematic review, although it was limited by heterogeneity and quality of source studies, it showed that a lower incidence of adverse events and lower mortality with moderate hydration than with aggressive hydration. This waterfall study, that is early weight-based aggressive versus non-aggressive goal-directed fluid resuscitation in the early phase of acute pancreatitis, an open-label multi-center randomized control trial, was designed to assess safety and efficacy of aggressive fluid resuscitation when compared with moderate fluid resuscitation in the patients with acute pancreatitis. Coming to the aim of study, it is to compare the impact of early and aggressive versus a moderate and more restrictive fluid resuscitation on the incidence of moderate to severe acute pancreatitis. The population that were considered were all the patients meeting with the diagnostic criteria of acute pancreatitis, intervention being the moderate fluid resuscitation, comparator group being the aggressive fluid resuscitation, and primary outcome which was measured was development of moderately severe or severe acute pancreatitis during the hospitalization. Coming to the materials and methods of the study, it was as already discussed, multi-center open-label randomized control trials, which was performed in 18 centers across 4 countries, including India, Italy, Mexico, and Spain. Inclusion criteria, all the patients older than 18 years within 24 hours from pain onset and who has received a diagnosis within 8 hours before the enrollment. And diagnosis of pancreatitis was determined by fulfilling at least 2 of the 3 criteria, that is characteristic abdominal pain, elevated serum amylase or lipase to 3 times upper limit of normal, and imaging demonstrating changes consistent with pancreatitis. And these were the group of patients which were excluded from the study, that is patients who had moderately severe or severe disease at the baseline itself, and patients with baseline heart failure or uncontrolled arterial hypertension, hyponatremia, hyponatremia, hyperkalemia, hypercalcemia, and estimated life expectancy of the patients being less than 1 year, and patients with chronic pancreatitis or chronic renal failure, and patients with decompensated cirrhosis. So after exclusion, the randomization was performed automatically by the electronic case report form application REDCap, and it was stratified by center, whether presence or absence of SIRS or suspected baseline hypovolemia. And this random assignment sequence was concealed from the trial team. And because there was the requirement of trial physicians to evaluate patients sequentially and adjust the fluid rate to address either volume overload or hypovolemia, this made double blinding impractical in this study. And sample size was calculated to achieve 80% power, including expecting 10% expected losses. It was considered to be 372 and 372 in each group. So this is the flow chart of the study. So altogether 676 patients were assessed for eligibility who had acute pancreatitis, which had the inclusion criteria. Among these, 427 patients were excluded who met the exclusion criteria. So among the remaining 249 patients, for the first planned interim analysis, they were allocated into 2 groups, into aggressive fluid resuscitation group and moderate fluid resuscitation group. Aggressive fluid resuscitation group had a total number of 122 patients, and moderate fluid resuscitation group had a number of 127 patients. In the study, there were no dropouts, but however, in the aggressive fluid resuscitation group, there were 25 patients who discontinued the intervention, mostly because of development of complications or shifting to ICU, or patients decided to leave the study. Whereas in the moderate fluid resuscitation group, around 10 patients have discontinued the intervention. Finally, 122 patients were analyzed in the aggressive fluid resuscitation group, whereas 127 patients were all analyzed in the moderate fluid resuscitation group. So after randomization, in the aggressive fluid resuscitation group, a bolus of 20 ml per kg ringalactate was given, then followed by infusion of 3 ml per kg per hour. At 3 hours, first safety checkpoint was performed, and if there was any suspicion of fluid overload, the infusion was immediately stopped or decreased. Then at 12 hour, 24 hour, 48 hour and 72 hours, there were certain goal-directed therapy checkpoints. So if the patient was suspected to have hypovolemia, then he was given another bolus of 20 ml per kg, and then infusion of 3 ml per kg was continued. If the patient had urine output less than 0.5 ml per kg per hour or SBP less than 90, then additional boluses of 20 ml per kg were considered. But if the patient had normal volemia, infusion rate has been decreased to 1.5 ml per kg per hour and was continued, and it was stopped after 48 hours if the patient was able to take oral feeds for greater than 8 hours. Whenever there was suspicion of fluid overload, the infusion was immediately stopped. Similarly, in the moderate fluid resuscitation group, not every patient was given a bolus. Only if the patient had hypovolemia, the patient was given a bolus of 10 ml per kg followed by infusion, 1.5 ml per kg per hour. Then at 3 hours, similar to the aggressive fluid resuscitation group, a safety checkpoint was performed, and if there was any suspicion of fluid overload, the intervention was stopped, infusion was stopped immediately. Then at 12 hours, 24, 48 and 72 hours, similar to that aggressive fluid resuscitation group, here also goal-directed therapy checkpoints were performed, and if the patient had hypovolemia, additional boluses were given, and if the patient had normovolemia, infusion rate of 1.5 ml per kg per hour was continued, and it was stopped after 20 hours if the oral feeding was tolerated by the patient for greater than 8 hours. When the patient had suspicion of fluid overload, then the infusion was stopped immediately. So in this study, these were the outcomes measured, the primary outcome being development of moderately severe or severe acute pancreatitis during hospitalization. Secondary outcomes being development of organ failure or local complications, duration of hospital stay, number of days in the ICU, use of nutritional support or invasive treatment, presence of SIRS at each checkpoint, and presence of persistent SIRS, and CRP levels in the blood at 48 and 72 hours, and a composite outcome of death, persistent organ failure or infected necrotizing pancreatitis, and symptoms as measured at admission and at each checkpoint. And fluid overload after randomization and during hospitalization was taken as a safety outcome, and to label it to be having a fluid overload, at least 2 of the 3 following criteria were required, that is either symptoms, physical signs or imaging evidence. And it was considered mild if it was responsive to medical therapy and if PaO2 by FiO2 never decreased to less than 300. Moderate if it was responsive to medical therapy but PaO2 by FiO2 was less than 300 at least once. And severe if mechanical ventilation or hemofiltration was indicated. Interim analysis was performed by the Data and Safety Monitoring Board, which halted this trial owing to significantly worse results with respect to safety outcomes in aggressive resuscitation group, which was not balanced by any trend towards the improved outcomes. So coming to the results of the study, sex and cause of disease were representative of patients with acute pancreatitis, but age here was younger. This may be because of the exclusion of certain coexisting conditions which was associated with older age. And patients in the aggressive resuscitation group received around 7.8 liters of Ringer's lactate during first 48 hours when compared with 5.5 liters in moderate resuscitation group. This is the table which shows the characteristics of patients at the baseline. As we can see, in both the trial groups, the baseline characteristics were evenly distributed. Coming to the primary and secondary outcomes, around 22.1% of patients in aggressive fluid resuscitation group and 17.3% of patients in moderate fluid resuscitation group has developed moderately severe or severe pancreatitis, and which was actually there was no significant in-group difference between both the groups, as we can see. And also coming to other outcomes, a composite of death, persistent organ failure or infected necrotizing pancreatitis also. 7.4% patients in aggressive fluid resuscitation group have developed them when compared to 3.1% in moderate fluid resuscitation group. And median duration of hospital stay also, it was around 6 days in aggressive fluid resuscitation group when compared to 5 days in moderate fluid resuscitation group. However, there was no significant in between group difference in both the groups, as we can see. But however, coming to the safety outcomes, it was observed that 20.5% of patients in aggressive fluid resuscitation group developed fluid overload when compared to 6.3% of patients in moderate fluid resuscitation group, which was statistically significant. But when moderate to severe fluid overload was observed, 4.9% was developed in aggressive fluid resuscitation when compared to 0.8% in moderate fluid resuscitation. Again, this was not statistically significant. This may be because the study was underpowered as it was stopped early because of safety concerns. Coming to the discussion, this trial showed that aggressive fluid resuscitation increased the risk of volume overload. Given the data showing increased harm without improvement with regard to primary outcome, this trial was stopped. But however, these findings do not support the current management guidelines which advocate aggressive fluid resuscitation in the patients presenting with acute pancreatitis. An increased risk of fluid overload was detected in overall population and also in the subgroup of populations, that is the populations with SIRS and without SIRS, and also patients with baseline hypovolemia. Though most episodes of fluid overload with aggressive hydration were non-severe, this situation was not balanced by improvement in outcomes. And also, as we have seen in this interim analysis, there was no significant between group difference in risk of development of moderately severe pancreatitis. But aggressive fluid resuscitation was associated with tendency towards higher intensity of symptoms and longer duration of hospital stay than moderate fluid resuscitation. So the findings of this waterfall study add to the growing body of evidence that aggressive hydration is linked to worse outcomes in critically ill patients. This might be because pancreatitis is associated with increased intra-abdominal pressure, which might be worsened by giving excessive intravenous fluids. However, this study had certain limitations. First of all, this was terminated at the first interim analysis, so it was underpowered to evaluate efficacy outcomes definitely. And also, given the very small between group difference in the risk of moderately severe or severe acute pancreatitis, maybe much larger sample size is needed to really show superiority of either one arm in this trial. But however, this was not possible as it might expose many other patients to much higher risk of fluid overload. And another limitation is that it was an open label trial which might have introduced bias. And in this trial, one more thing was that for the patients who could tolerate oral feeding also, it has mandated that 48 hours of IV fluids to be given in aggressive fluid resuscitation group and 20 hours in moderate resuscitation group, and this strategy may not reflect the real world practice. And they have stated that oral feeding could be started in either group at 12 hours if the pain score was less than 5, but recent trials indicate that immediate feeding should be considered in acute pancreatitis. So this effect of this immediate feeding on the fluid resuscitation needs to be evaluated. And also, exclusion of patients at high risk of volume overload meant that selection of patients with less severe disease. So to conclude, among the patients with acute pancreatitis, early aggressive fluid resuscitation did not lead to a lower risk of development of moderately severe or severe acute pancreatitis when compared to moderate fluid resuscitation group, but was associated with increased risk of fluid overload. Thank you.
Actually, I happened to listen to the speaker in IAP, this one. So the question asked was, how did they determine somebody is normovolemic, somebody was hypovolemic? That was what was asked. How did you correctly say it? So he is normovolemic in the ER.
One of the parameters we check is the hematocrit. So that whether that was taken into consideration for determining whether the patient is initially hypovolemic or hypervolemic. If they had taken this into consideration, the results have been different, or the stratification might be different.
They have taken, sir, actually clinical, biochemical, all the variables, sir. Skin turgor, tongue was taken as one variable, and one hematocrit was taken as biological variable BUN, and also I think mean arterial pressure was taken as one more variable, sir, to decide whether the patient was having normovolemia or hypovolemia.
This is the problem with the so-called evidence. By the time you come to a consolidated opinion, they come out with an opinion which is against, because we have been told that aggressive fluid resuscitation will reduce the amount of necrosis. But now these guys are telling it doesn't make a difference. So The thing is, and another thing is, why they have excluded moderately severe and severe pancreatitis? What is the need to exclude that? And finally, they have concluded that in case of acute pancreatitis, they should have mentioned it's mild pancreatitis. And why should a mild pancreatitis? I'll give an aggressive fluid resuscitation. So they are confusing us. And it's published in New England Journal of Medicine.
No, so one question that did come to my mind while reading this was, they're talking about aggressive hydration, which is a lot of fluid. Okay, so let's say a 60 kg person, so they're giving a 20 ml per kg bolus, which is 1.2 liters stat, followed by 3 ml per kg per hour, which would be around 180 ml per hour, which accounts for another 4.5 liters through the day. So that's almost 6 liters that you've given in one day. I don't think even any of us would remain normovolemic after receiving 6 liters of fluid. It's very improbable. So my problem with the design was largely that the amount of fluid that was given in the aggressive hydration group was too much. And the other group received reasonably less amount of fluid. And yeah, like you're saying, of course, they should mention, they considered mild pancreatitis because I had the opportunity to speak to Dr. De Medaria in UEG. So he told, this was a question that even I thought. So his hypothesis was, usually because of the hydration itself, patients become worse. The presumption is that they develop organ failures because they are not adequately hydrated. So they become moderately severe or severe because of that. And which is why they took only mild. That was what he told. So,
no, I have listened to Dr. Suresh Chari from Mayo Clinic, who said that if there is a singular factor which we can control in preventing development of necrosis is fluid resuscitation. But now this paper is against that. So what are we left with? And the point is...
They say not to give too much fluid, just give less fluid.
No, I mean, again, to the presenter, since you have reviewed it, so as sir is saying, is it associated with worse outcomes? Is it what that paper is saying? Aggressive fluid resuscitation?
Safety outcome, yes, sir. Primary outcome.
So the primary outcome, it is not shown that it is worse.
Yes, sir. Yes,
that severe pancreatitis, though they have not completed the study as yet.
Study, yes.
Coming again to the safety outcome, if you look at the safety outcome measures, the severe or moderate to severe fluid overload was not any different between the moderate versus the aggressive.
Yes, sir.
What was more was only the mild fluid overload. So why should that have been a safety consideration, if at all? Right?
They did not mention mild, sir. Overall fluid overload.
Correct.
That
so
will, yeah.
the subgroup where it says a moderate to severe was not any different between a moderate and an aggressive. So why should that have been? I mean, that is where I want sir's opinion. Like, when you look at this safety interim analysis, is this a good endpoint to stop a trial? One. Two.
Yeah.
And when do you look at, like, when to do this interim analysis, what we are interested to see is what happens to the local complication, what happens to the people who go into moderate severe pancreatitis. That is the outcome measure that we are really interested in. If some small such safety endpoints make the studies stop, I mean, are we good? I mean, are we okay to take those results as final? Like,
so I think that's a very, very important question. So always the safety and so first and foremost, this study was powered based on the primary hypothesis of mild going on to moderate to severe pancreatitis. So the sample size presumed that there is a 35% rate of progression from mild to moderate or severe based on, and which is why the so-called 740 sample size was taken. But now safety endpoints are always determined by the primary investigators. So they are the ones who determine when they are going to do the interim analysis, at what time points, what is going to be their end point to say that we are going to stop the study here. So it is purely at the investigator's discretion that safety endpoints or efficacy endpoints are determined. Now let's suppose the safety endpoint was not there, and let's say that in the aggressive group they showed that it was 40%, like only 5% rate of moderate to severe pancreatitis versus 10%. They could have defined that in the interim analysis and stopped the study at the same time. So there are, of course, this is purely at investigator discretion that this is done. So like you're pointing out, there is, even in randomized control trials, there is a lot of room to wiggle for investigators and to get a result that they want to show. So even in this trial, there is a lot of room for the investigator to wiggle and say that the safety endpoint, we clearly know that it was majority were mild. They didn't have severe fluid overload. Most of them responded to basic medical therapy or stopping the fluid itself. But at the end of the day, it was purely the investigator choosing to say that, yeah, okay, this is an endpoint I'm going to choose.
So again, the question is, what should be a good endpoint when you do this kind of randomized control trial? Singular points or this composite outcomes? Because some of the study designs come as composite endpoints, particularly intervention trials. I would be more, I might argue saying that death should be the primary endpoint. But if you look at pancreatitis, most of the intervention trials, they don't look at mortality alone. They look at other complications and they make it as a composite measure. Is that a supposedly good outcome, or how does it rate?
Okay, so now that you mentioned this, I think even in the Indian Pancreas Club meeting, there's a lot of discussion on the same thing. The extension trial, they used the outcome, the endpoint as a composite measure, not as singular events. Now, composite measures are good for the investigator because they are able to get away with doing fewer patients, a smaller sample size. So it's for investigator convenience that they will use a composite measure. So if you feel that you may not be able to achieve that sample size, you'll use a composite measure. If you want each and every outcome stated explicitly, then the sample size will automatically increase and you may not be able to finish the RCT in time. So which is why composite measures are chosen. Of course, they are not as valued as singular outcome measures. They are not going to be as good.
To the presenter, what is your take? What is your inference from this study? What would you take home as a message from this study? You're going to see these cases in and out, and you're going to manage them. So has it given you any sort of idea as to the next pancreatitis patient, this is how I'm going to manage?
This study is basically underpowered, sir, so I wouldn't conclude now that moderate fluid resuscitation is mandatory, but much larger studies are needed and to answer this
So you wouldn't give aggressive hydration to patients who come with severe pancreatitis?
I would follow whatever is...
I feel that you're risking. The patient is important to us. I think we need to make a decision on when to... That's how these people have got away with this study, because they have put in points, stop points, wherever they thought it was risking the patient. So I think you need to analyze and see. I still feel that aggressive therapy within 24 hours is still very critical to the patient and would probably benefit the patient. I think, Sridhar, what is your take on that?
So like you're saying, sir, the AG also recommends aggressive fluid hydration in their guideline for initial management of acute pancreatitis. Now this study shows quite the contrary, on the other hand. Now the AGA guideline would again state that the fluid that, the ceiling that they have given in the guideline would be around 4 liters. So this is still higher than that in the aggressive group. So that is the only issue here. Like you're saying, aggressive hydration, maybe the definitions of aggressive hydration vary between centers and institutes. So for what they may define as moderate hydration may be aggressive hydration for us in some way. So that is again a consideration. But from the study per se, clearly from endpoint, primary endpoint perspective, there is no change. But yeah, safety endpoint perspective, yes, there is a risk of fluid overload, and that is something that we have to be cautious about.
Was there any comment from the Manchester group on this paper? I think Ajit Sirivardhane was the one who really, the Manchester group was one who propagated this aggressive therapy at least for 48 hours. And they are the one who came with the goal-directed therapy.
So the editorial in NEJM also did not critique it too much. So usually you expect the editorial to actually have issues, but clearly they pointed out a safety endpoint. So clearly there cannot be a lot of critique on a safety endpoint. So everyone is, I mean, clearly patient safety is primary for everyone. So since they stopped it because patients were developing fluid overload, critiquing it and saying that the trial was a problem is not possible.
I think for the postgraduates, still we'll go by hematocrit and blood urea nitrogen. That should be the take home for the postgraduates.
Last we have Dr. Parag, who's going to be presenting a systematic review.
Good evening, everyone, teachers and my colleagues. So, my topic for today's journal club is proactive TDM, that is therapeutic drug monitoring versus conventional management for inflammatory bowel disease. It's a systematic review and meta-analysis. Therapeutic drug monitoring has been proposed to improve the outcome in patients treated with tumor necrosis factor alpha antagonist. TDM involves measuring serum drug concentration, that is typically trough levels, and anti-drug antibodies. Coming to the background of the study, what clinical observations we do in the daily routine are that this therapeutic drug TNF-alpha antagonist have a exposure-response relationship, that is the amount of drug that is being given to the patient and the response that the patient is giving to it. So it depends on the serum drug concentration. Apart from that, there is inter-individual variability in the drug concentration, that is drug clearance, that is one is through immune-mediated response and another is through the non-immune-mediated mechanism. So through the immune-mediated response, there are formation of neutralizing anti-drug antibodies. And the non-immune-mediated mechanism is that is associated with high inflammatory burden. For example, a patient is having high inflammatory burden, the response of the drug will be different. Then there is a concept of mechanistic failure, wherein despite adequate drug concentration, some patients respond to a particular class of biologics and some do not respond to it. So what is reactive and what is proactive therapeutic drug monitoring? So reactive therapeutic drug monitoring is something which that is measuring drug concentration and anti-drug antibodies to inform the dose adjustment of the biologics, this is generally strongly recommended by all the gastroenterological societies and consensus statements. Whereas proactive TDM is routine repeated measurement of drug and anti-drug antibodies regardless of the disease activity or regardless of the disease burden, to follow or to define a particular threshold of the levels in the blood. Whether the disease burden is less or not, it doesn't matter. So generally there is no such recommendation whether to follow proactive TDM or whether not to follow by the societies. So the selection criteria for this meta-analysis was all the patients with IBD being treated with TNF-alpha antagonist. The intervention arm saw the proactive TDM. The comparator arm checked for the reactive TDM or no dose adjustment. And the outcome was whether the patient is able to achieve or maintain in the remission. So the primary outcome of the interest of the study was failure to achieve or maintain clinical remission. Outcome was preferentially extracted at 12 months or if available at 6 months. They saw the subgroup analysis which saw whether the disease phenotype is either Crohn's or ulcerative colitis, whether dose adjustment is based on the symptoms or on the biomarkers, or there has been no dose escalation, which drug has been given, which class of the biologic has been given, and the phase of implementation of the therapeutic drug monitoring, either in the induction phase or in the maintenance phase. The secondary outcome of interest were failure to achieve or maintain the biochemical or endoscopic remission, risk of escalation of the index biologic, risk of discontinuation of the biologics, risk of developing anti-drug antibodies, and whether any risk is there for the proposed biologic trough concentration threshold, or whether there any serious adverse events are there. This is the study selection flow sheet. So basically what they did was they searched the database, they searched Medline, Embase and Central for the different studies which were looking at IBD and therapeutic drug monitoring. So out of that they extracted 5,000 odd studies. Out of the 5,000 studies, they extracted 157 full text reviewed articles. And again these articles were systematically reviewed, and out of that 9 RCTs were taken for the final analysis or the final meta-analysis. Coming to the result per se, so as you can see the forest plot, this is the forest plot which is comparing proactive TDM versus conventional management in the patients with IBD who are in clinical remission. As you can see, this result had moderate heterogeneity with I2 of 36%. Total number of the patients in this RCT was 1400. So as you can see, cumulatively there was no difference in the studies which will favor proactive TDM versus favoring conventional management as the end goal. This is the second forest plot which compared the proactive TDM versus conventional management in Crohn's disease per se, which also show that there was no significant difference at the end of the study. The third forest plot compared proactive TDM versus conventional management in ulcerative colitis per se, and they showed that there was no statistically significant difference whether we see proactive TDM or conventional management in the patients being able to maintain in the remission. The fourth forest plot showed proactive TDM versus reactive TDM, which again was not statistically significant. So this had around 7 to 8 studies. The risk of bias assessment was done with a Cochrane analysis tool. So as you can see, the first 4 studies had a good bias assessment, had a good, I mean, they didn't have any bias, whereas the last 4 studies had some amount of bias in either randomization or either in missing outcome data. So this is important because when we see the data per se of each study, it will help us in with seeing whether the study had any bias or not. There was no adverse events in the patients randomized to either proactive TDM or the standard of care. Coming to the discussion per se, so routine proactive TDM was associated with significantly higher rates of therapy escalation without any differences in the rates of development of anti-drug antibodies or success in achieving the target trough concentrations compared to the conventional management. So in one of the trial, that is Taxate trial, continued proactive TDM guided dosing was comparable to no further TDM at 1 year. Long-term follow of this trial up to more than 3 years showed no difference in the risk of IBD related hospitalization, surgery or corticosteroid use in either of the arm. So 56% higher risk of TNF alpha antagonist dose escalation in patients whom we are repeatedly seeing for, we are repeatedly checking for therapeutic drug monitoring. And in the absence of clinical benefit, this excessive dose escalation will contribute to cost escalation as well as some adverse events. In the 5 trials that reported risk of developing anti-drug antibodies, there was no significant difference in patients randomized to proactive TDM versus conventional management. So coming to the conclusion, this RCT had 1405 patients, in which 8 studies were seen in the adults, 1 study was in the pediatric age group. 8 studies were seen in the maintenance phase of the disease, while 1 study was seen in the induction phase. So as you can see, primary outcome at 1 year, if you see clinical remission, there was no benefit. If we see secondary outcomes, that is dose escalation, that was higher if we do therapeutic drug monitoring versus conventional management, that is seeing the disease per se or seeing the symptoms. And anti-drug antibodies, there was no statistically significant difference. So there is no benefit of proactive TDM compared with conventional management in achieving or maintaining clinical remission in patients with IBD. So wide implementation of routine proactive TDM in clinical practice will lead to inappropriate cost escalations and dilemmas in patients who are already in remission. Thank you.
A nice presentation, thank you.
Thank you, sir.
But, so what is your take on this meta-analysis? Like, what do you think? It is a heterogeneous group, or what do you think of the studies that have been included?
Sir, if we see this data and compare with Indian scenarios, it is difficult for us to measure the TDM repeatedly in patients. As we can see, it's due to the cost issues, and the sample has been are being processed at a particular center. They are not easily available. So I think for us, it's better to go for conventional management, seeing the disease burden per se, and seeing how the patient is responding to the biologics or the whatever treatment we are giving, rather than monitoring it repeatedly.
Are there any other questions from the floor? Thank you.
Thank you, sir.
Thank you so much for this. I think we had three very nice, interesting, different types of articles which have been presented. I think a final comment from Dr. Sridhar.
The students actually presented the articles reasonably well. The whole purpose was when Nubal sir told me that they wanted to start a journal club for TNISD, he wanted at least the way to go about it. So I chose 3 different study designs so that the students know how to critique each different study design. I did not choose different topics. I chose study design so that they'll have the approach for the next time maybe. So that was the intent here.
Dr. Sir, before you close, you told about how to analyze the data, all those things. But I want you to recommend to the postgraduates the wide array of material available. What journals, what articles to read? Say, for example, how do they select the article for a journal club? Do you have any, say like landmark trials or randomized control trials? So which to select for presenting in a journal club?
Yeah, so usually it would always be data from the high impact journals, 1. 2, it has to be clinically relevant. There's a lot of translational research that goes on. I don't know how much relevance it bears to clinical practice per se, unless of course you're doing that kind of research in your center. But from a clinical standpoint, if it's really going to change your practice, I think that is what has to be chosen. And thirdly, of course, always screen Indian journals also. Every edition of the Indian journal, always have a look at it. It's not just because the kind of research. There are two benefits to it. One, in your exam, they will always ask you, Indian data kya hai? And you should have answers at that time. Who's done the study, what they have done. And of course, it gives you a perspective on what people are doing in your own country so that you're able to do something similar.
Good evening all. Respected patrons, teachers, senior colleagues, junior colleagues and PGs, on behalf of our Tamil Nadu chapter, I would like to extend my sincere thanks to Dr. Sridhar Sundaram, Associate Professor Gastroenterology from Tata Memorial Hospital. Thank you, sir, for having come all the way from there. And definitely, I think the topic, you made it very interactive and interesting. A lot of discussion is going on. And thank you very much for that, sir. And also I'd like to thank all the chairpersons and the postgraduates who had active interaction in this session, so making this session very useful one to all of us. I'd like to thank Mr. Kumar and his team from Torrent Vista for having helped us in organizing the program, and I'd like to thank Taj Kanimara for providing us the ambience. I would like everybody to join us for dinner. Thank you.